Good morning, everyone. My name is Mushira, and I'm a fourth-year medical student. And today we're going to be going over ENDREP pathology practice questions. Um, Most of your MCQs and OSCE questions, and even MCQs, sometimes are going to revolve a lot on the histopath that they're going to be giving you in the lectures. And so, if you really, really hammer down those images in your brain, um, you're going to have a really, really easy time flying through those questions. But at the same time, if you're unable to do that, then you should definitely know the clinical presentation of each disease and how they manifest, and what are the labs that are being shown, especially in endocrine, and just yeah, like know the clinical presentation, the labs, and the diagnosis. And another thing, as I was talking about histopath images, and they've shown up a lot in our exam last year. There was also like a good chunk of radiology images that were shown to us last year, and they were straight out of the lectures, so you didn't even have to read the questions. If you knew what the image stood for, you could have easily guessed the answer. So hammer down both histopath and radiology images. I made a radiology summary file last year. If you guys still have the same lectures, that is. And I have it linked down in this lecture, so you guys can like open it up and check it out. If in case you guys have the same doctor giving you the same lectures, then I believe that that radiology file would be really, really helpful because it contains all the images from all our radiology lectures. Anyway, let's get started. Starting off with question number one. So just okay, so here we have a 27-year-old man. He's controlled his diabetes mellitus, so he's 27-year-old. This is probably type 1 diabetes. For the past 10 years with insulin injections, this morning, his roommate is unable to awaken him. The man is unconscious when brought to the emergency department on a physical exam. His temperature is 37, pulse is 91, respirations are 30, and blood pressure is 90/60. Okay, so respirations are high and blood pressure is low. His lab findings include a high plasma level of insulin actually, and a lack of detectable C-peptide. Urine analysis shows no blood protein or glucose, but plus for ketonuria. Which of the following conditions is most likely to be present? So it's definitely not MI, it's not bacteremia, and it's not hepatic failure because all of these would present differently. We're down to hyperosmolar syndrome, hypoglycemic coma, and ketoacidosis. Now, with hyperosmolar syndrome, it's usually seen in type 2 diabetics. It's not really seen in patients who have type 1 diabetes. And the pathophysiology for hyperosmolar syndrome is completely different than it is for hypoglycemic coma or ketoacidosis. And I'm going to be explaining that in a bit. Hypoglycemic coma and ketoacidosis, both of them have very similar clinical manifestations, but are again pretty much different. Now, with ketoacidosis, I'm going to start off by explaining what ketoacidosis is, and then we're going to, differentiate it from hypoglycemic coma. So usually, in type 1 diabetes patients, they don't have insulin, and when they don't have insulin, they don't really have the ability to transport glucose through the GLUT4 receptors into the organs. And so when the insulin is deficient or there is no insulin at all, the glucose remains within your blood. It's no longer getting taken up by the tissues because the transporters don't work without insulin. And so when the glucose stays in the blood, it is not being able to it's not being able to move into the tissues. What essentially happens is that the body undergoes into a starvation state. So even though you are hyperglycemic, the body just thinks you're starving off because the tissues are not getting that glucose. And so what happens essentially is that whatever minimal tissue uptake that was there, tissue glucose uptake that was there, was going to stop. The body's going to start breaking down glycogen because it's entering a starvation state, and it's going to start producing new glucose from breaking down proteins. So all of this is going to contribute to aggravating the hyperglycemia even more. And so when there's a lot of glucose in the blood, the plasma osmolality obviously increases, and that leads to symptoms like polydipsia. And because there's a lot of glucose in the blood, you want to kind of pee it out. So the way it does it is by osmotic diuresis, and because it's hyperosmolar, water follows solutes, and so you lose water, sodium, and potassium, and as a result you become hypovolemic. And another thing that happens while you are in starvation state is breakdown of fatty acids via beta oxidation. And so when that happens, ketone bodies are produced. And so now you have ketone in your blood and you kind of want to, get rid of that ketone. So again, you're going to pee it out, right? And also you're going to vomit it off. So the thing about ketone bodies is that they're acidic in nature. So what you're essentially going to come across is high anion gap metabolic acidosis. And whenever you have metabolic acidosis or alkalosis, your compensatory mechanism is usually through respiration, right? So if you have metabolic acidosis, you're going to have a compensatory mechanism that's going to be respiratory alkalosis. And respiratory alkalosis is basically blowing off carbon dioxide, and the way you do that is via hyperventilation, so small respirations. Apart from that, as we saw here, hypovolemia could lead to circulation failure or decreased tissue perfusion. And as a result of that, the body's mechanisms are not going to shift to, converting pyruvate to lactate. So serum lactate levels are going to go high, and that's going to further aggravate your metabolic acidosis. And in severe scenarios, it could lead to coma and death. So the main thing about ketoacidosis is that there's going to be no insulin, and when there's no insulin, your body is in a state of hyperglycemia. And you see this glucose both in the blood and urine, okay? And you also have ketones, which you will see both in blood and urine. The whole mechanism is that the body thinks that you're starving off and you actually have a lot more glucose in your blood. Now coming back to our hypoglycemic coma. Hypoglycemic coma essentially means that the patient is not basically having, the patient has taken a lot of insulin, and so they've kind of burnt off all their glucose that was there. And so when they wake up in the morning, they really have no glucose to function off. So this patient likely took a lot of insulin, like a high dose of insulin injection. And as a result of that, all his glucose stores started getting depleted and he entered a state of starvation. And the way we know that this patient, took a lot of insulin, and it was exogenous insulin, is because of C-peptide levels being detected, usually endogenous. We know that this patient took exogenous insulin mainly because there was no detectable C-peptide. Endogenous insulin usually has a good amount of detectable C-peptide. And that's why this can further point us to the diagnosis of type 1 diabetes. Anyway, so this patient likely took a lot of insulin, and as a result, all of his glucose stores went down, and the body entered a state of starvation, which is why you're seeing ketonuria here. But in hypoglycemic coma, you're going to see a lot of insulin, and you're going to see no glucose in your blood or urine, but you will see ketones in your urine and blood. Okay, so ketones are going to be there, insulin's going to be really high, glucose is not going to be there. In ketoacidosis, there's going to be no to little insulin, high glucose levels, and high ketone levels. From the lab findings, we know that this patient is definitely in a hypoglycemic coma rather than ketoacidosis. Okay, so that was that. And like I mentioned, I'm going to be coming to hyperosmolar hyperglycemic states. Now, this is usually seen in type 2 diabetic patients, mainly because in type 2 diabetic patients, the receptors are there and they're functional, but they are not, I would say they're not responding, they're not responding to insulin as efficiently as they should be. So you can say the receptors are kind of fried off. So even though, but then again, it's not majority of the receptors. There are still a few functional receptors left in your body. So when these receptors are kind of fried off and they no longer respond to insulin, you are still having a state where you're not able to push the glucose into the tissues because the receptors are sort of fried out. And so what happens is that, again, glucose accumulates within the blood. However, it's not a state of starvation because, like I said, it's not that, all the receptors are fried off. There's still few functional receptors left that will respond to insulin and that will take up glucose. So your body's not in a state of starvation. And the main thing here is there are no ketone body production and there is insulin here, whereas in diabetic ketoacidosis, insulin was deficient, ketones were present. And you just have a very, very high serum osmolality in osmolar hyperglycemic state over 600. Serum osmolality is over 320, and usually glucose levels are over 600. And there's normal pH, meaning there's no acidosis, mainly because there's no ketone body production because your body is not in a state of starvation. One thing about insulin is that it kind of pushes a potassium intracellularly. So if you don't have insulin, potassium kind of stays out. So the intracellular stores of potassium are getting depleted. And the reason why I say this is that it kind of makes a difference in management because you want to supply them with potassium to replete their the intracellular stores. And yeah, another thing about diabetic ketoacidosis was that a lot of potassium was lost from the body because of osmotic diuresis. Here, you don't necessarily see that total body potassium depletion, it's just intracellular potassium depletion. And yeah, these are the symptoms for both of them. And complications is that both of these can lead to, significantly life-threatening cerebral edema and death, and cardiac arrhythmias, particularly in this one, because again, you're losing potassium and that can have an effect on your heart. So treatment is by giving them two IV bore lines of fluid. Start by giving them insulin, replete their potassium stores, and also give them glucose because you want to prevent hypoglycemic coma. And moving on to question number 2. Here we have a 28-year-old, otherwise healthy man who has had headaches for the past 2 weeks. Physical exam shows no remarkable findings except for blood pressure of 174/16. 116. Abdominal CT shows an enlarged right adrenal gland. Right adrenalectomy is done. This is how it is shown. Which of the following lab findings would be most likely reported in this patient? So I'm for sure that this is a adenoma that's producing aldosterone solely and not cortisol, because if it was a cortisol producing tumor, then you would see the patient coming in with Cushingoid features. And this patient does not have Cushingoid features except and they only have elevated levels of blood pressure. So I'm for sure that this is an aldosterone producing tumor. And the way aldosterone acts is by basically, it acts on the collecting tubule of the kidney. So it's going to reabsorb sodium in water and it's going to secrete out potassium and H+. So that's essentially the reason why patients have elevated levels of blood pressure, because they're reabsorbing a lot of water and sodium. Now, which of the following lab findings will be most likely reported in this patient? Hyperglycemia, no. You could argue and say that if this was a Cushing's, sorry, not Cushing's, sorry. If it was a cortisol secreting tumor, then you could see hyperglycemia, but no, this is not a cortisol secreting tumor. Hyperkalemia, no. You secrete out potassium, so your body loses potassium rather than retaining potassium. Hyponatremia is not an answer because you will be hypernatremic because aldosterone helps with reabsorbing that sodium. Low corticotropin levels. Aldosterone has nothing to do with corticotropin. Corticotropin solely acts on ACTH, and that ACTH solely acts on cortisol and androgens. Okay, so this has nothing to do with aldosterone. Aldosterone is regulated with the renin-angiotensin-aldosterone system. Okay, so that's on option. Low insulin levels don't make sense. Low renin levels is the answer here, mainly because, like I mentioned, aldosterone is regulated by the renin-angiotensin-aldosterone system. So if your aldosterone is really, really high, it's going to have a negative feedback on the renin-angiotensin-aldosterone system, and it's going to suppress the levels of renin. So you're going to have low renin levels. Which is the same thing here. It's called, so if it's a adrenal adenoma that is secreting aldosterone, it's called as primary hyperaldosteronism with high levels of aldosterone, low levels of renin, and usually you have treatment-resistant hypertension. Secondary hyperaldosteronism usually occurs in patients who have fluid overload states, so heart failure patients or patients who have nephrotic syndrome. So they have fluid, but it's all in the wrong places, and your body kind of wants to compensate by pushing the fluid to the right space or to the right organs. And the way it does that is by activating the renin-angiotensin-aldosterone system. So with secondary hyperaldosteronism, you're going to see lots of renin because of the activation of the RAS, and you're also going to see aldosterone going to be high here. Another thing about the aldosterone producing tumor is the spironolactone bodies. These are usually the white little circles here that you see. You're going to come across them quite a bit. And because we were secreting out potassium and H+, we are going to be alkalotic. So the patient's going to be in a state of metabolic alkalosis. Yeah, that's about it. Moving on to question number 3. Here we have a 79-year-old previously healthy woman. She feels a lump in her right breast. The physician palpates a 2 centimeter firm mass in the right upper quadrant, non-tender right axillary lymphadenopathy. A lupectomy with ALND is performed. Microscopic exam shows an infiltrating ductal carcinoma. 2 of 10 axillary lymph nodes contain metastases. Flow cytometry on carcinoma cells show a aneuploid peak with a high S phase. Immunohistochemical tests show that the tumor cells are positive for estrogen and progesterone receptor, negative for her, and positive for cathepsin D expression. What is the most important prognostic factor for this patient? So when we're talking about prognosis, remember, whenever we talk about prognosis, we talk about metastases, okay? So here, the cancer is already spread to her lymph nodes. And so the most important prognostic factor for this patient would be presence of lymph node metastases. All of these others don't make sense. Asia diagnosis is not necessarily a prognostic factor. DNA content of the carcinoma, estrogen receptor positivity, these are mostly microscopic things that don't contribute to metastases. So yeah, here, axillary lymph metastases is the most common prognostic factor when we're talking about early stage disease. And yeah, you can read this off and just kind of, understand the risk factors for breast cancer. Anything that sort of increases estrogen within the body can lead to breast cancer or endometrial cancer. Anyone who has a history of breast cancer is more likely to develop, family history of breast cancer is more likely to develop, breast cancer as well. Mostly patients with BRCA1, BRCA2 mutations develop breast cancer. And usually, if you have an estrogen receptor positive breast cancer or progesterone receptor positive breast cancer, then it's more easier to get targeted therapy for it using selective estrogen receptor modulators, SERMs, so tamoxifen, stuff like that you can use on those sort of breast cancers. If it's a triple negative cancer, then it's definitely going to be more aggressive because you won't be able to give the targeted therapy treatment. And the way you can tell the breast cancer is now start invading the breast tissue, and it's no longer carcinoma in situ, is that it's going to start invading the Cooper's ligaments and the pectoral fascia. And then when it does that, the skin gets pulled up and the nipple gets retracted. So it usually presents with skin dimpling and nipple retraction. Moving on to question number 4, here we have a 41-year-old woman. She notices that her gloves from previous winter no longer fit her hands. Her facial features have become coarse in the past year, and her voice seems deeper. On physical exam, her blood pressure is 140. There's decreased sensation to pinprick over the palms and the distribution of her thumb and first 2 fingers. A radiograph of the foot shows an increased amount of soft tissue beneath the calcaneus. A chest radiograph shows cardiomegaly. Lab findings show a serum glucose level of 138, hemoglobin of 8.6, which of the following additional test results is most likely to indicate the cause of her physical in-lab findings. So this patient is clearly having a case of acromegaly. Everything's huge with her. And one of the most important lab findings that can indicate the cause of her physical findings is obviously failure of growth hormone suppression, because this could be acromegaly because of a growth hormone pituitary adenoma. All of these others don't necessarily make sense. Abnormal glucose tolerance test result will usually be seen in patients with diabetes mellitus, even though this patient is kind of, having, not kind of, but he's definitely hyperglycemic. That hyperglycemia is mainly because of that growth hormone. Growth hormone is diabetogenic. So this is more of an indication of type of diabetes rather than, a growth hormone secreting pituitary adenoma. Hyperprolactinemia, no. If it was a prolactinoma, then you would see signs of, if the patient hasn't reached menopause already, you would still see signs of like amenorrhea, galactorrhea, gynecomastia, things of that sort. So hyperprolactinemia is not an answer here. Increased serum TSH levels, again, completely ruled out. Loss of diurnal serum cortisol levels, this would not be seen here because this would be usually seen in a cortisol producing adenoma or a ACTH producing adenoma, and that's not the case here. So yeah, failure of growth hormone suppression, and here's a slide about acromegaly. So it's excess growth hormone release in adults, and the heart patients are typically presented with the coarse facial features, and one of the most important risk factor is development of cardiomegaly, because then that could lead to just diastolic heart failure, and it's the most common cause of death. So we kind of want to prevent that. Apart from that, impaired glucose tolerance, mainly because growth hormone is diabetogenic. Now, like I mentioned, serum growth hormone levels and uh, serum growth hormone levels would be really, really high, and also serum IGF-1 would be really, really high. And what I mean by failure of growth hormone suppression, so basically what happens is you have the anterior pituitary releasing growth hormone. The growth hormone goes, acts on the liver, produces IGF-1. The IGF-1 goes and acts upon the muscles and bones, and kind of does the whole amino acid uptake and protein synthesis. Growth hormone goes on the adipocytes and basically stops glucose uptake. So like I said, it's diabetogenic and causes breakdown of fat. Now, as a form of negative feedback, it can act on anterior pituitary itself. It can act on the growth hormone releasing hormone and exert a negative effect if there's too much growth hormone. IGF-1 can act on both anterior pituitary and the growth hormone releasing hormone. Apart from them exerting the negative feedback mechanisms on each other, there's also aging, obesity, and hyperglycemia that kind of suppress the release of growth hormone. So like I said, growth hormone is diabetogenic, meaning that it's going to prevent glucose uptake from the tissues, into the tissues. And so if you give someone more glucose, naturally, your growth hormone release should be suppressed, because that hyperglycemia is suppressing the release of growth hormone releasing hormone, further suppressing the release of growth hormone. So if you give someone more glucose, naturally your growth hormone should be suppressed, as a form of a compensatory mechanism. But in patients who have a growth hormone secreting pituitary adenoma, that's not necessarily the case. So even if you give them glucose, that's called as failure to suppress serum growth hormone after oral glucose tolerance test. So even if you give them glucose, you will not be able to suppress that growth hormone because it's an adenoma. Normally, it should be suppressed though. And usually treatment is via resection of it, or you can, give them somatostatin analogs or a growth hormone receptor antagonist like pivosomont. So yeah, moving on to question number 5. Here we have a 23-year-old woman. She is gravid to prepare to spontaneous abortion at 15 weeks of gestation. The male fetus is small for gestational age, malformed with syndactyly of the third and fourth digits of each hand. The placenta also shows 0.5 centimeter grape-like villi scattered among morphologically normal villi. Chromosomal analysis of placental tissue is most likely to show which of the following. So this is a classic case of gestational trophoblastic disease. And when we're talking about gestational trophoblastic disease, we're talking about partial mole, we're talking about complete mole, and we're talking about invasive, and we're talking about choriocarcinoma. This is benign, and these are malignant. Okay. So starting off with the placenta, the placenta itself is made up of like a functional unit called as a chorionic villi, and that chorionic villi is further lined by syncytial trophoblasts and cytotrophoblasts. Together, they're just called as trophoblasts. And if something's wrong within the trophoblast, essentially something's going to be wrong within that chorionic villi. Okay, so in partial moles, what happens is that these trophoblasts are going to only a section. So this is one chorionic villi, right? So only these trophoblasts, for example, only these trophoblasts are going to undergo hyperplasia. And when they undergo hyperplasia, naturally, this villi is going to be enlarged and hydropic. But it's only this section of the placenta that's undergoing hyperplasia. The rest of it's fine. So in partial mole, usually the trophoblasts are focally hyperplastic and focally enlarged villi, and the fetal or embryonic tissue is triploid, meaning that you have two sperms fertilizing one egg, which is why you have a triploid karyotype, so 69XXX or 69XXY or 69 XYY. So the fetal tissue is triploid, and there is so the fetal tissue is triploid, and the fetal tissue is also present. So that's what happens in partial mole. In complete mole, it's not just this part of the placenta being affected, it's the whole placenta being affected. So all of the trophoblasts are going to be hyperplastic, and all of the chorionic villi within the placenta are going to be hydropic and enlarged. So it's going to be diffusely hyperplastic, diffusely enlarged. And in this scenario, the fetal tissue is going to be absent, mainly because it's one sperm fertilizing an egg that doesn't have any DNA. And so when that happens, essentially you will not have any fetal parts remaining. So this is going to be diploid. So it's going to be 46XX or 46XY. This is mainly because of duplication of the paternal DNA and because there's no maternal DNA. With invasive mole, again, like I said, it's malignant. So the entire placenta is going to be affected. All the trophoblasts are going to be hyperplastic. All the chorionic villi are going to be hydropic. However, there's going to be invasion to the myometrium now. So that's why it's called as an invasive mole. And fetal tissue here is also absent. With cryocarcinoma, you have all the trophoblasts being hyperplastic. However, there is no longer, not hyperplastic, but they've progressed to atypia rather than hyperplasia. They've progressed to atypia. So when these trophoblasts become atypical, naturally you'll have a destruction of the villi. And so there's going to be no chorionic villi. There are going to be atypical trophoblasts, and now you have vascular invasion as well. Villi are going to be absent, and fetal tissue is kind of variable. So those were all our four gestational trophoblastic diseases. Mainly when you have just gestational trophoblastic disease, you have high levels of HCG, and the reason why you have high levels of HCG is because trophoblasts secrete HCG. So if you have hyperplasia of those trophoblasts, you'll have high levels of HCG, and this kind of contributes to hyperthyroidism. And it also contributes to hyperemesis gravidarum, where the woman comes in with a lot of vomiting. So those are the two main things that you want to watch out for when you have high levels of HCG. She's also going to come in with something called a size date discrepancy, where she's going to have a very, very, very huge uterus, even though she's like 4 weeks pregnant. Okay, so that's called a size date discrepancy. It's usually seen in complete mole rather than partial mole. And with partial mole, P57 is positive, meaning that it's sort of a protein that is maternally expressed. So in complete mole, it's going to be absent because there is no maternal DNA. And imaging for complete mole will show you a honeycombed uterus and a cluster grape-like appearance here. And partial mole has fetal parts, and risk of invasive mole and cryocarcinoma is a lot more in complete mole than it is in partial mole. And the way you treat this is via DNC, and sometimes you give methotrexate if you fear malignancy. So yeah, cryocarcinoma, and this is how they look like. I don't necessarily think that they're going to ask you to differentiate between how a partial and a complete mole look like under a microscope, because I don't think you would be able to figure that out just based on a histopath. You kind of need other clinical clues for it. Cryocarcinoma, on the other hand, one thing you have to know about cryocarcinoma is cannonball metastases. If you see multiple nodules in the lung and they tell you that she's having abnormal vaginal bleeding, um, and she has like these nodules in the lungs, and you know that it's cryocarcinoma. And basically they look like this under the histopath, and they have a lot of necrosis and hemorrhage going on here. So coming back to our question, so she had fetal parts present. When you know fetal parts are present, you know that it's 69XXY, which is basically partial mole. I remember in my step 1 exam, I had this huge paragraph of question. It was like probably like, I don't know, like a page long or something, and I was just talking so much random BS, and the only thing that could like give me the hint to the answer was the fact that there was presence of fetal tissue, and based off of that I just went and answered 69XXY. So if you know that the fetal parts are present, you can easily narrow down your diagnosis to partial mole in most scenarios. And again, they also mentioned that the villi was focally hydropic rather than diffusely hypertropic, because it was among morphologically normal villi. Okay, so that's how you do it. Going on to question number 6, here we have a 30-year-old nulliparous woman. She comes to the office for evaluation of infertility. She's been attempting to conceive for the past 2 years. Menarche was at age 11. Her menstrual cycles occur 2 to 3 times per day and last 7 to 10 days. So she has oligomenorrhea. The patient does not use tobacco, alcohol, or illicit drugs. Blood pressure is 120, normal, pulse is normal. BMI, however, is really high, so she's obese. She has mild acne and hair growth on the upper lip and chin. This patient is at a greatest risk for which of the following complications. So this patient has a classic case of PCOS, okay? And in PCOS, something that happens is chronic anovulatory cycles. So there is chronic anovulatory cycles, meaning there is unopposed estrogen production. And when there's unopposed estrogen production, that will lead to endometrial hyperproliferation. So you'll have endometrial hyperplasia, and that hyperplasia can sort of, cause it could like be a major risk factor for developing endometrial cancer, right? So the answer would be endometrial carcinoma. Adrenal atrophy does not make sense. She has PCOS. They have no relation to each other whatsoever. Chronic pelvic pain. You could argue that PCOS can also, increase the risk for developing endometriosis, and that could lead to chronic pelvic pain. However, again, there's no direct correlation as there is with endometrial hyperplasia and PCOS. Cushing syndrome, again, no direct correlation. Type 1 diabetes, nope. And vaginal intraepithelial neoplasia, now this would mainly be in the setting of like a STD. So with polycystic ovarian syndrome, usually what you have is hyperinsulinemia or insulin resistance, okay? And genetics and diet, all of that play a role to kind of tilt the balance of LH and FSH. So now you have increased LH to FSH ratio. When you have increased LH to FSH ratio, that's going to act on your theca cells to produce a lot more androgens. Okay, these androgens are going to be these androgens are going to go and they're going to cause all of these virilizing symptoms like acne and hirsutism. And furthermore, because and also a lot of these androgens are going to get aromatized to a different form of estrogen that's going to be called as estrone. Okay, so they're going to go to the adipose tissues, and they're going to be acted upon by 5-alpha reductase, and they're going to be converted to estrone. Now, this estrone will further lower down the values of FSH. So when FSH values go down, you're going to have anovulation. Okay, you're going to have anovulation, plus you're going to have a lot of cysts, because these follicular cysts are no longer, these follicular eggs are no longer, being matured enough, so they just form cysts. And also, like I mentioned, genetics, diet, all of that play a role, especially if the patient's obese, because she has a lot more adipose tissue in her body to kind of convert the excess androgens to estrone. And that estrone is just going to further cause a decline in FSH. So yeah, it's a very common cause of infertility in females. And it's diagnosed, it's a very clinical based criteria for diagnosis. So if you have like cysts on the ovaries, through ultrasound, or if you have like anovulation or oligomenorrhea or hyperandrogenism, and you have symptoms such as obesity and acanthosis nigricans. So you kind of need to have a clinical picture to diagnose PCOS. And yeah, you have high risk of developing endometrial cancer just because you have chronic anovulatory cycles that predispose the patient to having unopposed estrogen production, and that estrogen kind of just leads to hyperproliferation of the endometrial glands and endometrial hyperplasia, and that can further contribute to endometrial carcinoma. And yeah, so this is what happens. Same thing. Diagnosis for endometrial hyperplasia is usually to biopsy, and there's hyperplasia with atypia and there's hyperplasia without atypia. If you see something purple, just know that there's a lot of chromatin content in the cells, meaning that the cells are very much mitotically active, meaning the cells are very much cancerous. But if you don't see something that is as purple as this one, then you can tell that this is without atypia, meaning the cells have not reached that mitotically active stage. And it's usually a lot of glands proliferating in response to estrogen compared to stroma. So you're going to see a lot more glands compared to normal endometrial tissue. And while we're talking about endometrial hyperplasia, let's talk about endometrial carcinoma as well. So when we're talking about endometrial carcinoma, we have two types. We have the endometrioid one, which is usually the one that is responsive to estrogen, and then we have the serous one, which isn't responsive to estrogen. So endometrioid is usually the one that you see in the setting of endometrial hyperplasia. Serous is usually seen in cases of old age, and if patients have mutations within the p53 gene, and they're a lot more aggressive in nature. Whereas endometrioid, usually you will see P10 mutations here, and you will see mismatch repair enzymes, so MSH2 or 1, I don't know. But that's what you will normally see with endometrioid. And like I mentioned, anything that sort of increases estrogen in your body will lead to endometrial carcinoma because of endometrial hyperplasia. And this is how endometrioid type 1 carcinoma looks like. Like I mentioned, a lot of purple glands. And yeah, leiomyomas are usually fibroids. So these are smooth muscle tumors, and they're usually benign. They're associated with MED12 mutations. And again, they're also very much responsive to estrogen. So they will increase in size when there's a lot of estrogen, and they're going to decrease in size when there's like not much estrogen. So they're going to increase in size with pregnancy, and they're going to decrease in size with menopause. And this usually happens in like young adult females, middle-aged females. Sometimes it can be asymptomatic, but it can cause a lot of abnormal uterine bleeding and very high and menorrhagia as well. So sometimes a patient might come with iron deficiency anemia, but also patients with endometrial carcinoma can also come in with iron deficiency anemia because they would be presenting with abnormal uterine bleeding. And this is how leiomyomas look like. So there's just like a ball of white smooth muscles. And like I said, it's a tumor of benign smooth muscles. So you're just going to see spindle-shaped cells on histopath. And there's like different types of leiomyomas or fibroids based on the location where they are in the uterus. Leiomyosarcomas are usually more malignant, and they're usually de novo. So it's not like leiomyomas give rise to leiomyosarcomas. No, they just kind of happen. And these are also associated with MED12 mutations. However, the association is like a lot less compared to leiomyomas. And it's just areas of necrosis and hemorrhage, and you will see atypical cells here. So your smooth muscle cells just kind of no longer look like smooth muscle cells. And then this is the staging. I don't necessarily think they're going to ask you about staging. They're just know that stage 1 usually involves the endometrium and the myometrium. Stage 2 goes to the cervix. Stage 3 goes to other pelvic organs, and stage 4 has distant organ metastases. Okay, so question number 7 here, we have a 2-month-old boy. He's brought to the emergency department because of progressively worsening flopiness and poor feeding. The infant was born in Eastern Europe via uncomplicated vaginal delivery to a 38-year-old woman, and then immigrated to the United States with his family. The parents described the baby as a good baby who rarely cries and sleeps through the night, but has difficulty to rouse for breastfeeding. Stools have decreased to every other day and are small and pellet-like. Physical exam shows a hypotonic infant with a large anterior fontanelle, large tongue, and a reducible umbilical hernia. He has low tone and is unable to hold his head erect on his own. No other abnormalities are seen. Which of the following is most likely the cause of this patient's condition? So it's hypothyroidism, classic case of congenital hypothyroidism, or cretism, as you would like to call it. And especially given the fact that this patient is coming from a background where background of an underdeveloped area where the mother may have not received proper nutrition during her pregnancy, that's probably what led to development of congenital hypothyroidism. So yeah, you have these findings. They're called as a 6P. So pot-bellied, pale, puffy child, protruding umbilicus, protuberant tongue, and poor brain development. So you have to give them thyroid hormone supplements ASAP, because then it would become irreversible intellectual disability. So these are the findings. If you know what the clinical picture looks like, it's a very easy diagnosis. Question number 8, here you have a clinical study being conducted in patients diagnosed with either type 1 or type 2 diabetes. Patients with either of them develop complications of accelerated and advanced atherosclerosis. So both type 1 and type 2 diabetic patients will have advanced atherosclerosis. All untreated patients have elevated levels of hemoglobin A1C. Which of the following features common to patients with either type 1 or type 2 diabetes is most likely to be found by this study? So basically, they're asking which of these following options are common to both type 1 and type 2. So association with certain MHC class, nope, it's only seen in type 1. High concordance rate in monozygotic twins is usually seen in type 2. Marked resistance to the action of insulin is also usually seen in type 2. Non-enzymatic glycosylation of protein is seen in both, and this is only seen in type 1. So the answer is going to be D. Here's like a difference, like a differentiating slide between type 1 and type 2. The basic concept is type 1, you have autoimmune destruction of beta cells, so you don't have insulin production in the first place. Type 1 is where you have resistance to the insulin productions, your receptors are fried. Progressive, but then eventually beta cells kind of fail, and you'll have beta cell failure in type 2 as well. And usually type 1 is diagnosed at a very early age, type 2 is at an older age. And yeah, here in type 2, you're usually going to see islet amyloid polypeptide deposits, and in type 1, you will see leukocytic infiltrate. The thing about both of them is that because there's hyperglycemia in both these scenarios, that excess glucose has to go through two pathways, either the glycation pathway or the sorbitol pathway. So the glycation pathway will lead to vascular diseases like small vessel disease and large vessel disease. So small vessel disease could be retinopathy. Just give me a second. Okay, so sorry about that. So like I mentioned, if there's too much glucose in your body, you kind of want to take two pathways. So you have the glycation pathway and then you have the sorbitol pathway. So glycation pathway is usually the one that is going to affect your vessels, and sorbitol is usually the one that's going to affect your nerves. So usually glycation pathway can lead to small vessel and large vessel diseases. Small vessel disease could be hypertension, retinopathy, glomerular sclerosis, whereas large vessel disease could be, anything that has to do with the coronary arteries, so MI, peripheral vascular disease, cerebrovascular disease, etc. With osmotic damage, usually, like I mentioned, you're going to see them in neurons. So you're going to be seeing neuropathy, diabetic neuropathy, gastroparesis, things of that sort, cataracts, those things. Now, moving on to question number 9. Here we have a clinical study of women diagnosed with ovarian neoplasms that reveal 1 in 200 develop masculinizing signs and symptoms. And these include hirsutism, acne, breast atrophy, and amenorrhea. These women are found to have well-circumscribed lobulated formula mass lesions averaging 5 centimeter. Microscopically, they have plump pink cells that show positive immunochemical staining for inhibin. Which of the following neoplasms are most likely to have these features? So usually, if you see realizing symptoms and you see that these patients have a adnexal mass, then your answer for sure is ceratolytic cell tumors. Granulosa theca cell tumors produce a lot of estrogen, so rather you would see things like breast tenderness, abnormal uterine bleeding because of endometrial hyperplasia. Endometrioid carcinoma would not produce realizing symptoms. Dysgerminomas and Brenner tumor, usually dysgerminomas have high levels of ATG and LDH, and here you just have positive immunohistochemical staining for inhibin. Brenner tumors, again, are not going to produce realizing symptoms. Now, when we're talking about ovarian tumors, we usually see that the surfaces of the ovary from the surface epithelium or from the egg, and from the other tissues surrounding it, so either the follicle or the cortex. And again, they're associated with BRCA1, BRCA2 mutations, and mostly they are going to present as an adnexal mass with abdominal descent. And anything that basically reduces the number of ovulation, so would basically decrease the risk of developing ovarian tumors, whereas anything that would increase the number of ovulations, that would increase the risk of developing ovarian tumors. So anyone who's had previous pregnancies, they have had breastfeeding history, OCPs, the number of ovulations. And CA-125 levels are a good way to monitor the disease in response to the treatment. However, it's not a good way to diagnose the tumor itself. Okay, and when we're talking about epithelial tumors, we're talking about two types. We're talking about serous ones, and we're talking about mucinous ones. Serous ones have a epithelium that is very similar or to like fallopian so serous ones have cells that are very similar to your fallopian tube epithelium, okay? And mucinous ones have cells which are very similar to your mucinous epithelium that's found in the cervix, okay? And then we have germ cell tumors which arise from the egg, and we have the sex-core stromal tumors that arise from the tissues surrounding the egg. So that could be the cortex and that could be the follicle. Now, moving on to epithelial tumors, we start off with serous ones. So we have the adenomas, which are benign. We have the adenocarcinomas, which are malignant. And adenomas usually look like, like a normal cyst, and they usually have columnar epithelium with villi because, like I mentioned, they resemble the epithelium of the fallopian tube. And they're most commonly associated with BRAF and KRAS oncogene mutations. Whereas serous adenocarcinoma, they have something called psammoma bodies, and they're a lot more malignant, and they're associated with p53 mutations, and they could spread to the peritoneum and the omentum necrosis. This is borderline serous tumors. Kind of memorize it because it has nothing to it. I just think it's a garbage diagnosis. But this did show up on our exam, and the only way I was able to get this down was because I just kind of remembered this picture for borderline serous tumor. Moving on to mucinous epithelial tumors, we have the adenomas and the carcinomas as well. The adenomas are benign, the carcinomas are malignant. So this is a multiloculated cyst that's filled with gelatinous fluid, and like I mentioned, mucinous has epithelium that is similar to the cervical epithelium. So you're going to see tall columnar cells with mucus that's going to push down the nuclei here. And associations like KRAS and smoking. So this association is only seen in mucinous carcinomas or adenomas. It's not seen anywhere else. Similarly, for mucinous carcinoma, this could be metastatic as well from appendiceal or GI tumors, and it could lead to pseudomyxoma peritoni, where you have intraperitoneal accumulation of mucinous fluid. And it has areas of solid structure, areas of cystic structure, areas of necrosis, areas of hemorrhage. Basically, there's absolutely no coherent gland structure when it comes to mucinous carcinomas, and this is also associated with KRAS and smoking. And yeah, you have a lot of nuclear atypia here. This is just a picture of pseudomyxoma peritoni. They could give you, this picture, and they could ask you which of the following tumors is responsible for this consequence, and the answer would be mucinous carcinoma. I don't know why this slide is repeated, so I'm just going to delete that. Moving on to germ cell tumors, we start off with mature or cystic teratomas or dermoid cysts. I kid you not, this is like my top 3 fears. I cannot fathom having a ball of cells that's filled up with like skin, teeth, and sebaceous glands and bones and cartilage. Like, no, it's literally my top 3 fears. But yeah, dermoid cysts are usually very much benign, and they arise from all 3 germ layers. So the ectoderm, the mesoderm, and the endoderm. So if they arise from all 3 layers, you will likely find manifestations of all 3 layers. So you'll find skin, you'll find bone, you'll find cartilage, you'll find smooth muscles. Here you'll find glands. So you'll basically find everything. This is how it looks like on histo. So you have skin here, you have glands here, you have hair follicles here, you have like a smooth muscle here. So it's kind of like a mixture of everything. This does have a malignant transformation to squamous cell carcinoma, but again, that's pretty much rare. And then moving on to monodermal or specialized teratomas. Okay, so this is like an extension of your dermoid cyst, but it's only from 1 layer. So you have the struma ovary, and then you have the carcinoid tumor. So struma ovary is basically the one that's kind of resembling the thyroid gland, and it has the thyroid follicles which secrete which secrete T3 and T4. So you will have symptoms of hyperthyroidism in those scenarios. Carcinoid tumor, you've known this from GI, but it's a very characteristic appearance of salt and pepper. So if you see anything like salt and pepper, it's a carcinoid tumor, and this sort of appearance is constant throughout the body. Wherever you see a carcinoid tumor, you will see this sort of appearance, and you will be able to tell it's a carcinoid tumor. So it's not just, specific to the ovary, you kind of see it everywhere. And the thing about carcinoid tumors is that you will see 5-hydroxytryptamine in the blood and in the urine. Now, moving on to immature teratomas, these are more malignant, and apart from having all the three germ layers, they also have the neuroectoderm. So they're usually malignant and have the neuroepithelium involved as well. Just kind of memorize how they look like, because it's much more easier to identify a dermoid cyst than it is to identify an immature teratoma. With dysgerminomas, these are usually synonymous to the seminomas in males. So they have a very characteristic appearance of fried eggs, okay? So if you see this appearance, you know that it is a dysgerminoma. Another thing about dysgerminomas is that they're going to have high levels of HCG and LDH. So they'll say that tumor markers like HCG and LDH are elevated, plus they'll show you this, you will know the answer is dysgerminomas. And they're usually unilateral, associated with c-KIT mutations. Yolk sac or endodermal sinus tumors, something that's very characteristic to them is the Schiller-Duvall bodies. These are basically bodies that look like a glomeruli. And the tumor markers in this case would be alpha-fetoprotein and alpha-1 antitrypsin. The way I remembered alpha-fetoprotein was specific to yolk sac tumors was because yolk sac was for fetus and alpha-fetoprotein. So that's how I remembered alpha-fetoprotein kind of stood for yolk sac tumors. And remember Schiller-Duvall bodies, yeah. This one's malignant and also very much aggressive, and is going to present with a rapidly enlarging pelvic mass, whereas dysgerminomas are usually seen in a much younger population, but they're also very much malignant. Now, coming to your sex cord stromal tumors, these are usually arising from mostly the granulosa cell. And we know the granulosa cell is mainly responsible for producing estrogen because FSH acts upon that granulosa cell to convert the androstenedione to estrogen, and then LH is acted on the theca cells to produce androstenedione, which is why the whole imbalance leads to a lot more, in PCOS, leads to a lot more androstenedione production because there's a lot more LH. Anyway, I went off a tangent there, but just know that granulosa cell produce estrogen. So if you have a granulosa cell tumor, then it's definitely going to manifest as hyperestrogenism, meaning that the patient will present with abnormal uterine bleeding because of endometrial hyperplasia and things of that sort. So sertoli cell tumors are very much easy to diagnose because they have a very, characteristic presentation of virilization symptoms. So, acne, hirsutism, anything of that sort will, directly lead us to a diagnosis of sertoli cell tumors, especially if it's within ovarian adnexal mass. And then this is how it looks like. They kind of resemble the seminiferous tubules in your, in your testes. Then you have the granulosa cell tumors, and these are usually something that's, characteristic to them as the colic bodies, which are basically these bodies here, and they produce estrogen. So usually in postmenopausal women, like I've mentioned for like the 5th time, you're gonna have an abnormal uterine bleeding because of endometrial hyperplasia. In girls who are like young, they'll reach puberty early, so precocious puberty. You'll have breast tenderness and things of that sort. Tumor markers and have been here. Moving on to fibromas and thecomas. I don't think it's as high yield, but just know the picture. Know that this stands for fibromas or thecomas. The one thing about fibroma is that you have Meigs syndrome, which is basically a triad of pleural effusions, ascites, and fibroma. So if a patient comes in with an adnexal mass and they have pleural effusion, they have a very, very distended abdomen, you know it's a fibroma because of, like a diagnosis of Meigs syndrome. Okay, so that's a very, very, very rapid review of our ovarian tumors. Moving on to the next question. Here we have a 54-year-old woman who noticed a lump in her right breast. On examination, she has an ill-defined 1 centimeter mass in the upper outer quadrant. The mass is cystic on ultrasound, and excision is done, and microscopically, the mass shows predominantly fibrocystic changes, but the lesion shown in the figure also is present. Fine needle aspirates of both the breasts reveal additional foci of similar cells. Which of the following breast lesions is most likely to produce these findings? So, just want to check if I'm even audible. Okay, right. So anyway, the the really, really annoying thing about breast cancers is that you need to know how they look like on histopath. And it's like the most annoying thing because when it comes to carcinoma incidus and when it comes to invasive carcinomas, you will be narrowed down to identify them based on their histopath. Inflammatory breast lesions are a different entity, and it's much more easy to diagnose inflammatory breast lesions than it is to diagnose these breast cancers. So that's like the really annoying thing about breast cancer is that you will be forced to choose based on the histopath that they provide. Um, because almost all of them have very similar presentations of a breast mass. And that's literally about it. Calcifications, mammogram, and that's it. LCIS is the only one, which is lobular carcinoma in situ. That's the only one there that's actually not having any calcifications and does not produce a mass. So that's a bit of a trickier diagnosis. You have to do a fine needle aspiration for that. But either ways, you are forced to choose based on the histopath they provide. So before we answer, let's just go over breast lesions really, really quick. I'm going to do a rapid review of all the breast lesions and yeah, so we have inflammatory lesions, we have benign epithelial lesions, we have carcinoma in situ, invasive carcinoma, and others. So inflammatory lesions are usually going to have a very acute presentation, okay? And not like fibrocystic disease, you have non-proliferative ones, you have proliferative with atypia, without atypia, and with atypia. With atypia is most of the time synonymous to carcinoma in situ actually. So it's not really that important, but the way they manifest is in the form of cysts or fibrosis or adenosis. Okay, so these are like the most common patterns that you will see in fibrocystic diseases. And then you have carcinoma in situ, you have invasive carcinomas and other tumors as well. This is just like a picture of where each of the tumors lie. So yeah, starting off with inflammatory lesions, acute mastitis. This is almost always going to be seen in patients with patients who've who are breastfeeding. So they're going to come in with a tender erythematous breast fever. In this scenario, however, you do not ask the mother to stop breastfeeding. You will tell her to continue to breastfeed, and you will treat her with antibiotics like cephalexin. Thus, it's more of a staph aureus skin infection than it is anything else, okay? Mammary duct ectasia, again, you will have a woman coming in telling she is having thick white discharge, and she also has a palpable subareolar mass. And this is mainly because the duct underneath the nipples are kind of extended. So that's why she's having such sort of a presentation. And that usually happens because of chronic inflammation that can cause fibrosis. And this can mimic DCIS because DCIS is again ductal carcinoma in situ. So it's a cancer or a carcinoma in situ of the ducts. So this can mimic DCIS because you're going to have a lot of cells within the ducts. So you want to watch out for that. But usually DCIS does not have thick white discharge like mammary duct ectasia. Fat necrosis is usually, always so the patient's going to come in, she's going to come in and you'll see a painless, and she'll complain of a painless breast mass. And then you're going to do a mammogram and you'll see microcalcifications and you're going to freak out and you're going to freak the patient out and everyone's going to freak out because you're like, oh my God, what if it's a cancer? But you're going to do biopsy, and on biopsy, you will find out that there's foamy macrophages and there's cholesterol clefts, and you're going to be like, you know what, it's fine, it's just fat necrosis. And this usually happens in response to some sort of breast injury. And most of the time, this breast injury kind of goes unnoticed. So that's why the women come in with like masses out of nowhere, and you have to do mammogram, and the mammogram kind of freaks everyone out. So yeah. Fibrocystic disease, we're talking about proliferative breast lesions without atypia. So you have epithelial hyperplasia. This is how the normal epithelium should look like, just two layers of the epithelia and myoepithelial cells. Hyperplasia is just a lot of cells, epithelia and both myoepithelial. Sclerosing adenosis is where you have proliferation of both the acini and the ducts. So the surrounding connective tissue kind of just gets fibrosed, and so it kind of leads to compression of lobule as well, and you will see microcalcifications. And it will also present as a palpable mass, but this is without atypia, so it doesn't, really raise the risk of cancer. Complex sclerosis or radial scar. Here you have basically glands which are trapped in a hyalinized stroma. So in the center, you'll have like hyalinized area where the glands are trapped, and then it's dilated glands are kind of just radiating out on the periphery. And this very much looks like an invasive carcinoma. However, it's just a complex sclerosis or radial scar. Moving on to papillomas. Papillomas are usually seen in are like fibroepithelial tumors, so they'll usually be seen with bloody or serous discharge, but most often it's going to be bloody discharge. So if a patient tells you that she's having bloody discharge, it's definitely papilloma, and she's going to have palpable subareolar mass. The way you differentiate papilloma from mammary duct ectasia is mammary duct ectasia has thick white discharge, whereas papillomas have bloody or serous discharge. Gynecomastia is just, increase in the collagenous tissue inside the breast in response to prolactin or, progesterone. However, there's no lobule formation. Coming to carcinoma insidious, we start off with DCIS, which is usually ductal carcinoma insidious. So you have hyperplasia of ductal cells that fill the lumen of the duct. So this is how it's going to look like. Comido is a form of DCIS, and it's usually high grade. And then these are other forms of DCIS. So you have the micropapillary form and the cribriform form. The micropapillary form has like these papillary structures at the periphery. And the cribriform form looks like, someone just took a cookie cutter and kind of placed it on the tissue. And so now you have like these cookies here. These guys are low grade. So yeah, this is how DCIS looks like. Again, similar presentations where you have a mass, or a mass may not be palpable. That's kind of variable if the mass is going to be there or not. But on mammogram, you will see calcifications. And usually the way you treat it is by resection. And if it has spread, if it has metastasized, then you want to do axillary lymph node dissection or radiation. We have Paget's disease next, which is basically happening in the setting of a DCIS or an invasive cancer. So here what happens is that there's extension of cancer into the lactiferous ducts as well as the skin. So that's why the breast is going to be erythematous, the nipple is going to be itchy, and like you're going to have like bleeding patches over the nipple. It's going to be erythematous, and on histo, you're going to see Paget cells here. So again, very easy diagnosis, but this almost always happens in the setting of an invasive cancer or DCIS, okay? LCIS, on the other hand, usually what happens is you have decreased E-cadherin expression. Again, you will not find any sort of calcifications or any masses. So this is usually an incidental finding on biopsy. And with LCIS, this is usually multicentric or bilateral. DCIS could mostly be unilateral, okay? So this is how LCIS looks like. It's lobular carcinoma insidious, so you have hyperplasia of the cells within the lobules and not the ducts. Moving on to invasive breast cancers, starting off with invasive ductal carcinoma. So again, when it comes to invasive ductal carcinoma, it is most definitely going to present with a fibrous rock hard mass, okay? And because it's invasive, it's going to also go and invade into your pectoral fascia and your pectoral fascia, and yeah, basically it's going to cause skin dimpling and nipple retraction because it's already invaded the structures there, and you have positive E-cadherin expression here. This is how it looks like. So basically, as you can see, the ducts are kind of like now obliterated, mainly because the cancer is moved out. Invasive lobular carcinoma has the very, very characteristic appearance of a single file. So the cells are arranged in like single file appearance, and here you don't have E-cadherin expression, and there is a very high risk of invasive lobular carcinoma having multiple lesions or it being bilateral. And with invasive lobular carcinoma, there's a variable desmoplastic response. Okay, so you might not see skin dimpling or nipple retraction as often as you see in cases of invasive ductal carcinoma. Coming to medullary carcinoma, this is triple negative, and it's just very, very purple. So that's how I remembered it. I was like, oh, it's so purple. It's definitely medullary. And the thing about medullary carcinoma is that it's usually going to have anaplastic cells kind of mixed with plasma cells and lymphocytes and, other inflammatory cells. And it's very well circumscribed, and it mimics a fibroadenoma. And again, there's no desmoplasia here. Mucinous adenocarcinoma, very easy to recognize because it's like tumor cells floating, underneath mucin or within mucin. So it's very easy to recognize. Tubular adenomas, honestly, I don't know. It's not gonna lie, it's like really low yield. Just memorize the picture and you're gonna be good to go for tubular carcinoma. Remember that it has a good prognosis. Stromal tumors, we usually have two main ones. We have the fibroadenomas and the phylloides tumors. So fibroadenomas are very much mobile. So they're called as mouse tumors because they move so much. And usually when you take a biopsy and you cut it, you'll see that there's fibrous tissue and like like a pearl white and whorled pattern. Treatment is lobectomy. Phylloides tumor are having leaf-like patterns of connective tissue. So that's how you could remember phylloides and fibroadenomas. And fibroadenomas usually are very well-defined mobile masses. So yeah, if you remember how each of these look like, you will be able to answer most of your questions, okay? So mammary duct ectasia usually will be having hyperplasia within the ducts, but then it is going to have a very characteristic thick white discharge. Fat necrosis, you're going to see foamy macrophages with, cholesterol clouds. Epithelial hyperplasia, just a lot of cells within the duct, and then this could mimic DCIS. However, um, uh, DCIS would usually present with the mass and microcalcifications. Sclerosing adenosis is just a lot of glands and a lot of ducts, and all the other surrounding tissues kind of fibrosed. And radial scar or complex sclerosis kind of looks like a star is what I remember. Papillomas usually have bloody serous discharge, and gynecomastia is just a lot of increase in the collagenous tissue instead of lobular tissue. DCIS usually looks like a lot of cells within the ductal lumen, okay? And Paget's disease have Paget cells with them, and they have a very classic presentation of eczematous patches over the skin and nipple. LCIS looks like a lot of cells within the lobules itself. And when we were talking about invasive cancers, I just found it really hard to kind of diagnose invasive ductal carcinoma solely based on this. So I would diagnose it just kind of by eliminating other options. And invasive lobular carcinoma is very easy to diagnose. It's just like a single file appearance in most scenarios, and they will tell you that's like decreased cadherin expression. Medullary carcinoma, again, easy diagnosis, purple. Mucinous carcinoma, easy diagnosis, it's just with mucin. Stromal tumors and very easy diagnosis as well. Fibroadenomas, mobile mass, that kind of looks like, like a whole pattern. And phylloides tumor, leaf-like lobulations of connective tissue. So moving back to our question. So does this look like infiltrating ductal carcinoma? I highly doubt because the ducts are kind of empty, so it's not infiltrating ductal carcinoma. Could it be lobular carcinoma in situ? Could be, yes. Could it be a malignant phylloides tumor? No, phylloides tumor usually has a leaf-like appearance. Medullary carcinoma is very much purple, and mucinous carcinoma has mucin around it. So this is definitely lobular carcinoma in situ. Okay, now question number 11. We have a 62-year-old woman. She's felt a lump on her right side of the neck for 5 months. On physical exam, she has no palpable lymphadenopathy. A fine needle aspiration is done and she undergoes a thyroidectomy. So lump on the right side of her neck for 5 months. So she has a 3 centimeter solid mass within the right thyroid lobe. And this is the histopath that's shown. 6 months later, she has pain in her right thigh, and a radiograph shows a fracture of the right femur. A radioiodine scan shows uptake localized to the region of the fracture. Which of the following is most likely the diagnosis? So just by basing off of the clinical presentation, this has to be cancer because there's been metastases to the bone. And usually when there's been metastases to the bone, it's hematogenous metastases, which is usually seen in follicular carcinoma and not papillary carcinoma. Papillary carcinoma would have lymph node metastases, okay? So just by basing off of the clinical picture itself, I can tell this is follicular carcinoma. It's not granulomatous thyroiditis because that would follow up with that would precede a viral infection. Hashimoto's also, she would have symptoms of hypothyroidism. Here she had nothing. In non-Hodgkin lymphoma, again, she would have palpable lymphadenopathy, which she doesn't have here. So just by basing off of that clinical presentation, I would go with follicular carcinomas. But then again, we're gonna go over and discuss all like thyroid cancers. So starting off with thyroid adenomas, this is usually just a benign solitary overgrowth of the thyroid tissue. Most of them are non-functional. So if you have the capsule here, um, you have the thyroid capsule here. Here you have normal cells. Here you have the adenoma. Notice that how this does not invade the capsule. So when it doesn't invade the capsule, this is most likely an adenoma, okay? unlike follicular carcinoma, because follicular carcinoma and adenomas look very much alike on histopath, and you need to get a core biopsy to determine which one of them has vascular invasion and which one of them does not, and which one of them has capsular invasion and which one of them does not, okay? So that's that. Usually adenomas are cold or non-functional. They don't produce, thyroid hormones. Coming to papillary carcinoma, this is like the most common one, usually presenting with cysts and like fibrovascular structures. The thing that is really, really important for papillary carcinoma is to remember how they look like. So they'll have intranuclear inclusions and grooves. They're going to have psammoma bodies. You're going to have nuclei that resemble the orphan Annie nuclei. So you have to memorize these. They are mostly associated with RETs and PDC rearrangements and BRAF mutations. BRAF mutations are usually the ones that have a poor prognosis. And if you have a child with prior history of, radiation therapy, then they have a higher risk of developing papillary carcinoma. And once again, they will have palpable lymph nodes because the metastases is to the lymph nodes. Moving on to follicular carcinoma, which is going to be very much similar to your adenomas, like I said. So this is an adenoma, this is a thyroid capsule, it doesn't go out. However, here, as you can see, this is already invading the capsule, so this does go out. So that's how you will be able to tell that this is a follicular carcinoma rather than an adenoma. Apart from that, this has hematogenous spread, and particularly to the bone. And it's associated with the RAS mutations, and triple P mutations is how I remembered it. So PAX8 and PPAR, then P10 and PI3K. What you will see is positive for TTF1 and thyroglobulin, which is kind of like a tumor marker in case of thyroid cancers. And yeah, moving on to medullary carcinoma, this is basically from the parafollicular cells or the C cells. So calcitonin production is going to be evident, and when calcitonin is produced, it kind of pushes down calcium. And when that necessarily happens, you might get symptoms of, like tetany, spasms, arrhythmias, things of that sort. Usually you will see like sheets of cell that are mixed with amyloid stroma. So this is the amyloid stroma. And if you do stain it with Congo red, you're going to get apple green birefringence. And these are usually associated with MEN2A and 2B mutations, mainly RET mutations, and other paraneoplastic syndromes associated with medullary carcinoma is abnormal ACTH production or vasoactive intestinal peptide production. And one thing that I want to clarify here is that if you only see RET mutations, then it's probably medullary carcinoma. However, if you see RET mutations with PTC rearrangements, then it's definitely papillary carcinoma. Okay, so you have to have RET with PTC, because if you only have RET, then it's medullary carcinoma. Undifferentiated anaplastic carcinoma usually resembles renal thyroiditis, which is the rock hard thyroid mass that is, enlarging. So it's going to compress on other structures, and when it compresses on other structures, it's going to produce symptoms like dysphagia, hoarseness, shortness of breath. Usually has a very poor prognosis, and it's seen in patients who've already had prior history of thyroid cancer. Again, it's double P positive with RAS and TP53 mutations. And it's also negative for TTF1 and thyroglobulin. Now, like I mentioned, there was an option about Hashimoto's there, but I mentioned that she would have hypothyroid symptoms, where she would be dull, drowsy, she would have cold intolerance, anything of that sort, but she didn't have it there. But again, Hashimoto's is like the most common cause of hypothyroidism in iodine sufficient regions, and this is usually an autoimmune condition. So if someone says that, oh, I've had and autoimmune conditions, they have a tendency to go in together. So if someone comes in telling you that I have diabetes or I have SLE, then it is likely that they could also have Hashimoto's. And usually they are at a risk of developing diffuse large B-cell lymphoma. The pathophysiology with Hashimoto's is, antibodies against your TPO, which is a thyroid peroxidase enzyme that helps in the production of T3 and T4, and also antibodies against thyroglobulin. And it's most of the pathophysiology is mediated by CD8 T cells, CD4 T cells, and interferon gamma. And on histopath, you will see germinal centers and germinal centers with lymphoid aggregates. So, you have a germinal center here. So these are germinal centers with lymphoid aggregates, and you will see Hürthl cells. Um, a, a, a variant of Hashimoto's would be postpartum thyroiditis, but that's usually very mild and it is self-limiting. So patients can go back to their normal state of thyroid. Um, and this usually happens less than 1 year after delivery. But in this case, you won't see germinal centers or Hürthle cells, rather you would just see lymphocytes. And the thing about Hashimoto's is that even though it presents like as a hypothyroid condition, this will start as hyperthyroidism because your antibodies are gonna, destroy this follicular cells, and when those follicular cells get destroyed, they're going to release a lot of T3 and T4. So you're going to have a transient hyperthyroid state called as hashitoxicosis. Then that's going to be followed by a euthyroid state and then a hypothyroid state. And this is the decorvian thyroiditis that we're talking about, very painful enlarged thyroid. And this is usually preceded by a viral infection. What you're going to see is like multinucleated giant cells here. Okay. And again, the very same presentation here starts off as hyperthyroidism, goes to euthyroidism, hypothyroidism again, and then euthyroid. Now, moving on to question number 12. Here we have a 74-year-old woman. She's admitted to the hospital in an obtunded condition. Her temperature is 37, pulse is 95, respirations are 22, blood pressure is 90/60. She appears dehydrated, poor skin turgor. Serum glucose levels are massively high, 872. Urine analysis show plus for glucosuria, but no ketones, protein, or blood. Which of the following factors is most important in the pathogenesis of the patient's condition? So she is having glucosuria. She has no ketones. She has very high levels of glucose. She's definitely having hyperosmolar hyperglycemic state. And that's usually seen in patients with type 2 diabetes. So peripheral insulin resistance is the answer here. Now, question number 13. We have a 31-year-old sexually active woman who's had mucopurulent vaginal discharge for 1 week. On pelvic exam, the cervix appears reddened around the os, but no erosions or mass lesions are present. A pap smear shows numerous neutrophils, but no dysplastic cells. Cervical biopsy shows marked follicular cervicitis, and which of the following infectious agents would most likely produce these findings? So, no dysplastic cell, meaning no coilocytes, so HPV is already ruled out. Mucopurulent discharge, okay, and she has cervicitis. So, Candida albicans, nope. That would be usually on a patient who's on immunosuppression, and they will have cottage cheese type of discharge instead of mucopurulent. Chlamydia could be an answer here because chlamydia both has mucopurulent discharge and is also going to cause cervicitis. Gardnerella vaginalis usually causes bacterial vaginosis which is like like a thin white discharge with a fishy odor. Herpes simplex virus is usually going to cause genital ulcers that are going to be painful and recurrent, and she doesn't have ulcers here. And like I said, no dysplastic cells, so human papillomavirus ruled out. Neisseria usually Neisseria can cause cervicitis and it can cause discharge. However, the cervicitis here is follicular cervicitis, which is very specific to chlamydia, and it's not seen with Neisseria. So that's ruled out, and trichomonas is usually seen as they're going to tell you the patient has strawberry cervix, and they're going to tell you that she has a green discharge or a malodorous discharge. So that's not the case here. The answer is going to be B. And this is just a table of how I basically characterize what STD the patient had based on if the presentation was painful or painless. So painful presentations are usually seen in herpes simplex virus and Haemophilus. So herpes simplex usually will have a lot of ulcers that are going to be on an erythematous or red base and tender lymphadenopathy, and they're going to have other systemic symptoms like fever, myalgia, headaches, stuff of that sort. And also, they're going to be recurrent. Haemophilus, on the other hand, is usually going to have a very deep ulcer with like pus coming out of it. And of course, tender lymphadenopathy is seen in both of them, but here the lymphadenopathy can also produce pus, okay? So it can also suppurate. Painless lesions are usually the ones seen with syphilis and chlamydia. So syphilis usually will start off as a single ulcer, and it's going to be a non-purulent base just with interated borders that are hard. Chlamydia is usually going to start off with shallow ulcers, that are very small, and that's why they can be missed, and then painful buboes, which are basically painful lymphadenitis. So it's usually the lymphadenitis that is painful in chlamydia, and it's not the ulcers themselves. And this is also a later presentation. It's not an initial presentation. Initial painful presentation will narrow us down to these two guys. Again, I found this table in first aid super helpful for STDs. You guys can read over it. These are common vaginal infections again that you guys can read over. Same thing. Torch infections again. I don't think they were as high yield in our exams, but I know for a fact that they're there in your lectures, so you can go over the slide and kind of get like a whole review of torch infections. Okay, now moving on to question number 14. We have a 21-year-old woman. She's noticed increased fatigue and 7 kg weight loss without dieting over the past 4 months, increased anxiety and nervousness with diarrhea, diffusely enlarged thyroid gland. Her temperature is 37, pulse is 103, respirations are 28, blood pressure is 140, and a radionuclide scan of thyroid shows diffuse increase in uptake. And this is her histopath. Which of the following what is likely to produce these findings? So she's a classic case of hyperthyroidism. Okay, she's a classic case of hyperthyroidism, and one of the most common causes of hyperthyroidism is Graves' disease. So antibodies against TSH receptor is the answer. All of these four are basically hypothyroidism. So yeah. Now with Graves' disease, we're talking about antibodies which are against the TSH receptor. We're talking about antibodies which are against TSH itself. So they're going to prevent binding of TSH to the TSH receptor. We're talking about thyroid growth stimulating antibodies as well. So all of that can contribute to excessive stimulation of the TSH receptors and excessive release of T3 and T4. And it can also contribute to diffuse enlargement of the thyroid gland. And these receptors and these antibodies don't just act on these TSH receptors, they also go on to act on your dermal fibroblasts and your fibroblasts within the eyes or the retroorbital fibroblasts. And what they're going to do within the dermal fibroblasts, they're going to act upon them and they're going to basically cause inflammation there and lead to pre-tibial myxedema. And they're going to go into your retroorbital fibroblasts and they're going to act upon them, cause inflammation, and cause release of glycosaminoglycans, which are composed of chondroitin sulfate and hyaluronic acid. So that kind of causes swelling around your eye, and that will produce a very characteristic symptom of, lid lag and exophthalmos. And this often usually presents during stress, so pregnancy, infections, anything of that sort. And histology, you will see tall follicular cells with scalloped colloid. So this is a colloid, and then there's like scalloping on the periphery of it. That's how I remembered that this was specific to Graves' disease. And then here are other things that are associated with hyperthyroidism. There's toxic multinodular goiter, which is basically you have like patches or foci of hyperfunctioning follicular cells. And these are usually not responsive to TSH. They're not responsive to TSH in the sense that they don't work they don't work in response to TSH, but they do work autonomously, meaning that they just continuously secrete T3 and T4, and it doesn't matter how TSH acts upon them because the receptor for that TSH is fried. So it's and then on radioiodine uptake scan, these are usually going to be hot nodules. And know for a fact that when it's a hot nodule, these are rarely malignant. If it is a cold nodule, then that's a sign of concern and we have to biopsy the lesion. Thyroid storms are usually seen in cases of acute stress, when the patient's having infection or surgery and they have, they have a prior history of hyperthyroidism that is not treated. So in that case, it just gets worse. Your body starts releasing a lot more T3 and T4, and that can cause you to enter, tachyarrhythmias. And so you want to treat it with 4Ps, so beta blockers, you want to treat it with PTU, you want to treat it with glucocorticoids and potassium iodide. Then you have the job-based out phenomenon and other causes of goiter. But yeah, remember TMG, which is toxic multinodular goiter, and remember thyroid storm, and remember Graves' disease, because these are the most common ones that they can bring you up during your exam for hyperthyroidism. Now here we have a 34-year-old woman who noticed a bloody discharge from the nipple of her left breast for the past 3 days. On physical exam, the skin of the breast appears normal. Okay, so bloody discharge, and this can already tell us the answer is fibroadenoma. Okay, no masses are palpable, that's fine, but we know it's bloody discharge, so it's fibroadenoma. Because acute mastitis, she would be breastfeeding. She's not breastfeeding. Intraductal papilloma would present with a thick white discharge. And sorry, not fibroadenomas, intraductal papilloma. Fibroadenomas will not present with discharge. I'm so sorry about that. I'm so sorry about that. But fibroadenomas are not going to present with discharge. They're going to present with a mobile, mass. But this is an intraductal papilloma because of the bloody discharge. Phylloides tumor does not present with bloody discharge. Sclerosing adenosis does not present with bloody discharge. It's the intraductal papilloma. And confusing counterpart of intraductal papilloma is mammary duct ectasia, but ectasia presents with a thick white discharge and papilloma presents with a bloody discharge. Okay, now moving on to question number 16. Here we have a 43-year-old woman. She has increasing lethargy and weakness over the past 3 years. She has cold intolerance, wears a sweater in the summer. 1 year ago, she had menorrhagia, but now she has oligomenorrhea. She has difficulty concentrating. Her memory is poor. She has chronic constipation. Physical exam is her temperature is low, her pulse is low, her respirations are low, her blood pressure is low or on the lower end. She has alopecia. Her skin appears coarse and dry. Face, hands, and feet appear puffy with dough-like skin. Hemoglobin's fine. Her hematocrit is fine as well. Glucose is all right, and then creatinine is also fine. The representative microscopic appearance of the causative disease is shown. So this is classic hypothyroidism, okay? And the most common cause of hypothyroidism, like I said, in iodine sufficient region was Hashimoto's. And in Hashimoto's, you see anti-thyroid peroxidase antibody. And on the histopath, as you can see, there are germinal centers with lymphoid aggregates here, okay? So very easy diagnosis. Moving on to question number 17. Here we have a 37-year-old woman who states that most of the time she feels fine, okay? This is important. She has had episodes of palpitations, tachycardia, tremor, and diaphoresis, and headache over the past 3 months. When her symptoms are worse, her blood pressure is measured in the range of 155/90. She collapses suddenly one day and is brought to the hospital where she has ventricular fibrillation, and that is converted to sinus rhythm. On physical exam, there are no remarkable findings. Which of the following lab findings is most likely to be reported? So she has relapsing and remitting symptoms of palpitations, tachycardia, tremor, diaphoresis. She has also very high blood pressure. So these so whenever a patient comes in, with symptoms like these, and they're telling you that, oh, they come and go, then it's a very high indication of pheochromocytoma. Okay, so with pheochromocytoma, the lab findings would be increased urinary metanephrines and increased catecholamines. But increased urinary metanephrines, which would be VMA and HMA, these are not specific to pheochromocytomas. They can also be found in neuroblastomas. So this is not an answer. Rather, the answer is going to be E because it's more specific to pheochromocytomas. So pheochromocytomas are most commonly associated with men's syndromes. And they're usually tumors of the adrenal medulla in adults, and they're mostly coming from the neural crest cells, which give rise to chromaffin cells. This isn't really as important. Don't use this to diagnose someone with pheochromocytomas. It's kind of BS. Symptoms would be high blood pressure, headache, sweating, just like our patient had, tachycardia, pallor, all of these, and they usually occur in spells, so they relapse and remit. Sometimes they can also secrete EPO, so that can lead to polycythemia. And because they're derivatives of neural crest cells, they're going to be positive for neural tumor markers like chromogranin and synoptophysin and a C positive. And like I mentioned, catecholamines and metanephrines like HVA and VMA are going to be high in urine and plasma, but HVA and VMA are also high in neuroblastoma, so we don't solely rely on this for diagnosis. We need to see increased catecholamines as well. And the treatment usually is you want to start off with alpha blockers first and then go on to beta blockers to kind of avoid having a hypertensive crisis. So you use phenoxybenzamide as an alpha antagonist, and then go on to a beta blocker. So this is how pheochromocytoma looks like on histopath, and this is the gross pathology of it. Just kind of remember how it looks like. And then with neuroblastomas, these are usually seen in children, and they will produce a mass effect. However, they're not going to cross the midline. Okay, so you will see abdominal distension, but it's going to be localized. And thing about neuroblastomas is that you usually don't see hypertension. Rather, you will see someone with dancing eyes, dancing feet type of thing. So it's called as opus clonus myoclonus syndrome. And again, VMA and HVA are going to be high in neuroblastomas, both here in urine and plasma. And something that is specific to neuroblastomas is the homor right rosettes. So these things here. These are pathognomic for neuroblastomas. And again, they're also going to be positive for neural markers like bombesin, NSC, chromogranin, synaptophysin, anything of that sort. And they're also associated with N-mice oncogene. The thing about neuroblastomas is that they can mature into ganglioneuroma, which is a more benign form of the disease. Okay, so this is how a ganglioneuroma looks like. Okay, moving on to question number 18. So here we have a 61-year-old woman who comes to the office because of a neck lump. She is otherwise in good health and she has no other symptoms. Temperature is 36, blood pressure is 115, pulse is 78. Physical exam, there is a non-tender firm nodule in the left lobe of the thyroid. Lab results show a normal TSH level. Thyroid ultrasonography shows 2 centimeter hypoechoic thyroid nodule with increased central blood flow. So whenever you see increased central blood flow or increased blood flow to any region, that likely indicates that the region is hypermetabolic. And usually regions which are hypermetabolic are because of them having a likely potential to become cancer cells. So increased central blood flow could indicate that the patient has cancer. FNA shows large overlapping nuclei containing finely dispersed chromatin. Numerous intranuclear inclusion bodies and grooves are okay. So just based off this, I know this is papillary carcinoma because I know that there are intranuclear inclusions seen in papillary carcinoma. So the answer is going to be F. Okay, question number 19. So we're almost done. I think we have about, I don't know, I think there were like 26 questions, so we're almost done. We have a 19-year-old woman who's a gravida 1, para 0, 29 weeks of gestation. She comes to the emergency department because of severe right upper quadrant pain, okay? The patient suddenly developed the pain this evening after dinner. The pain was associated with acute nausea and vomiting, and she has no headaches or visual changes. She has no other chronic medical conditions, no medications, and her blood pressure is very much elevated. So 160 over 100, she's at 29 weeks of gestation. This is definitely either gestational hypertension or preeclampsia. Pulse is 84, abdomen is tender over the right upper quadrant, but no rebound on or guarding is present. Hemoglobin's 8, so hemoglobin's low, okay. Urinalysis show 3+ protein, so we know it's preeclampsia mainly because there is going to be proteinuria or end organ dysfunction in the setting of high blood pressure for preeclampsia. Which of the following associated labs are going to be seen in this patient? Now, when we're talking about preeclampsia, we're talking about the complications of preeclampsia as well, and we can see the hemoglobin is pretty low here. And she has right upper quadrant pain, meaning that she's having microscopic thrombotic angiopathy within the liver, meaning that the liver is kind of getting so when we're talking about preeclampsia, we're talking about proteinuria and or end organ dysfunction. That end organ dysfunction just happens to be in the liver, and so when it is in the liver, it's going to inevitably present as right upper quadrant pain. And when you see when you see things such as elevated blood pressure, and when you see hemolysis, when you see because liver is damaged, I'm assuming there's elevated liver enzymes, and when you see elevated liver enzymes, there's going to be hemolysis, elevated liver enzymes, and low platelets, okay? So we're usually diagnosing someone with HELP syndrome, which is a complication of preeclampsia. So alanine aminotransferase is going to be high, mainly because liver is getting damaged, and direct bilirubin's high because of hemolysis, and platelets are low. So the answer is going to be A. And when we're talking about hypertension in pregnancy, we're talking about gestational hypertension. So this is basically just pure hypertension without proteinuria, without end organ damage. And this happens after 20 weeks of gestation. And the reason why this cutoff is so important is because if there's gestation before 20 weeks, then it probably means that the patient was already hypertensive and it was just found out during pregnancy. So gestational hypertension is usually after 20 weeks of gestation. And Preeclampsia is basically hypertension with either proteinuria or end organ dysfunction after 20 weeks of gestation as well. And the major pathophysiology for preeclampsia is that you have abnormal placental spiral arteries. And when you have abnormal arteries, they can lead to endothelial dysfunction and vasoconstriction, and that could further aggravate hypertension. Risk factors are, so whenever we're talking about obstetrics and gynecology, mainly obstetrics, if someone has had preeclampsia in their prior pregnancies or gestational hypertension in their prior pregnancies, that is the major risk factor for developing any of those conditions in their current pregnancy. So anyone who's had a risk factor, anyone who's had a risk of developing preeclampsia in their previous pregnancies will have increased risk of developing preeclampsia here as well. Multifetal gestation, chronic hypertension, CKD, autoimmune diseases, obesity, and complications of preeclampsia would be placental abruption, mainly because, as we know, placental spiral arteries are abnormal. So that can easily cause placenta to kind of rupture or, kind of slaw off from the uterus. Coagulopathy, renal failure, pulmonary edema, uteroplacental insufficiency, eclampsia, or HELLP syndrome. So you want to start off by obviously giving them these hypertensives. You want to give them IV magnesium sulfate to prevent seizures, and treatment is to deliver the child, and prophylactic therapy would be through aspirin. This when you deliver the child, and if the child is, let's say, preterm, then you have to give them steroids because you want to make sure the lung is undergoing maturation. Eclampsia is when you have preeclampsia with seizures, and usually here in this case, you have to give them stat IV magnesium sulfate. So, and you also have to deliver the baby immediately. Like this is emergency case. So you have to give them IV magnesium sulfate and you have to deliver the baby immediately because that can cause death, because that can lead to death due to stroke or any sort of hemorrhage. And HELLP syndrome, like I said, this is preeclampsia with thrombotic microangiopathy of the liver. So there's basically thrombosis within the small vessels of the liver. So that's going to cause liver damage, leading to elevated liver enzymes. There's also going to be hemolysis and there's going to be low platelets. And HELLP syndrome doesn't necessarily have to happen in the setting of proteinuria. It can happen, or hypertension. It doesn't necessarily have to have those two scenarios. It can happen in the absence of those two as well. And then one of the main complications of HELLP syndrome is the development of a subcapsular hematoma, which is basically, in the liver. And if that ruptures, then that can lead to massive circulatory shock, so hypertensive shock, and it can cause DIC. And again, treatment is immediate delivery. Now, moving on to question number 20, here we have a 40-year-old man who experiences weakness and a fatigability of 2 months duration. A physical exam, so fatigability of 2 months, 40-year-old, physical exam yields no remarkable findings. Lab shows serum calcium of 11.5, elevated, sort of elevated, mainly because it's like normal calcium values are between 8 to 10. Inorganic phosphorus of 2.1, low. Serum parathyroid hormone of 58, elevated. A radionuclide bone scan fails to show any areas of increased uptake. What is the most likely cause of these findings? So this is a classic case of primary hyperparathyroidism. And the reason why I'm saying it's primary because PTH is elevated. And so that leads to elevation of calcium levels and decrease of phosphate levels. So I know it's primary. If it was secondary is usually in response to CKD. So when you have CKD, the kidney is mainly responsible for producing active form of vitamin D. And when vitamin D isn't there, you no longer absorb calcium and phosphate at the same rate. So you have decreased levels of calcium and phosphate. Apart from that, normally the kidneys should reabsorb calcium and decrease and secrete phosphate. And because the kidneys are no longer functional in CKD, they're no longer reabsorbing calcium and they're just kind of reabsorbing a lot more phosphate, or they're not secreting out phosphate. So again, calcium levels decline, phosphate levels go up, and that sort of leads to increased levels of PTH. Okay, so that's secondary. In tertiary hyperparathyroidism, usually you will see both calcium levels are going to be elevated and PTH levels are going to be massively elevated. And this also happens in the setting of, CKD. Here, so we know this is, definitely hyperparathyroidism. Chronic renal failure is not an answer here because in that case, we would see low levels of calcium, high levels of phosphate. Hypervitaminosis D is not an answer here because in that case, we would see high levels of both calcium and phosphate, because vitamin D is helpful in absorption of both calcium and phosphate. Medullary thyroid carcinoma is not an answer because this secretes calcitonin, which brings down calcium. And then parathyroid adenoma, carcinoma, and hyperplasia. Out of these three, adenomas tend to be the most common one. Carcinomas usually would have very, very high PTH values. 58 isn't that high of a PTH value. So carcinomas would usually have a very high PTH value. And hyperplasia is usually seen in the setting of men's syndromes. And based off of this clinical picture, the patient clearly does not have any other endocrine abnormalities. So we're going to go with adenomas also because they're the most common ones. And this is just the same thing that I went over here. So primary hypoparathyroidism is usually because of a parathyroid adenoma or hyperplasia. So that's going to lead to hypercalcemia and hypercalciuria. So you're going to have stones and polyuria as well. You're going to have hypophosphatemia. So basically, parathyroid hormone is going to go act upon the bones and it's going to cause release of calcium into the bloodstream by causing lytic lesions within the bones. And when it breaks down the bone, ALP is released as well. There's also going to be increased urinary CAMP. Usually it's asymptomatic, however, it can present with bone pains, psychiatric overtones, constipation, abdominal or flank pain because of kidney stones, stuff of that sort. And one thing about primary hyperparathyroidism is that it can accompany brown tumors, which are basically tumors containing osteoclasts, mainly because of increased activity of PTH. And secondary hyperparathyroidism, like I mentioned, it was in the setting of CKD. And here you will see renal osteodystrophy, which is basically bone lesions in response to the renal disease. And then this is basically tertiary, where you have refractory hyperparathyroidism from chronic kidney disease. So very, very high levels of PTH and also high levels of calcium as well. Now, again, the same concept of adenomas and carcinomas comes here in parathyroid glands as well. It's an adenoma if it doesn't invade the capsule. It's a carcinoma if it does invade the capsule. So capsule here is intact. So this is a parathyroid adenoma. Capsule here is like broken down. So this is a carcinoma. Moving on to question number 21. We have a 63-year-old woman. She has a screening mammogram that shows an irregular density with microcalcifications. On physical exam, there are no lesions of the overlying skin and there is no axillary lymphadenopathy. An excisional biopsy of this specimen shows no mass on sectioning. Microscopic exam shows the findings in the figure. What is the most likely diagnosis? So this kind of looks like cookies. And I know this cookie pattern is seen in DCIS, so I'm just going to go with it. Choroid carcinoma, you would see mucin, tumor cells floating in mucin. Infiltrating ductal carcinoma, you would see basically ducts being obliterated and ducts being obliterated, and there's just being a lot of cells that are purple outside the ducts as well. Infiltrating lobular carcinoma, you would have single file appearance of the cancer, and then medullary carcinoma is just all purple. Papillary carcinoma, I'm not sure if they mean papillary carcinoma of the thyroid, because I don't know why this is there. But if they do mean papillary carcinoma, I'm assuming they mean the micropapillary form of DCIS, which is again tying to B. So question number 22, we have a 15-year-old girl who's brought to the office because of amenorrhea. She's never menstruated, but her mother underwent menarche at the age of 14. So the patient has no chronic medical conditions. She takes no medications. She does not use tobacco, alcohol, or illicit drugs. She plays violin for high school orchestra, captain of her junior varsity tennis team. These are not really that important, but she's not sexually active, and she's 5'9", so she's pretty tall, taller than most people, most girls for their age, and then weight is 65. Her BMI is 21, so she's not overweight. She has fully developed secondary sexual characteristics, and a pelvic ultrasound shows a vaginal canal with rudimentary uterus. So this is primary amenorrhea, okay, because she's never had a menarche. And with primary amenorrhea, so let's just go over these options. We have 21 hydroxylase deficiency, alpha hydroxylase deficiency. Usually, if that was the case, then she would not have. She wouldn't have had. She would have had like virilizing symptoms. She would have had virilizing symptoms like acne, hirsutism, things of that sort, because androgen levels would be pretty high if she had this. Androgen insensitivity syndrome, she would not have had secondary sexual characteristics in the first place because her organs would not be responsive to the androgens because receptors would be fried off. Kalman syndrome is usually seen when a person is not able to reach puberty because they have decreased levels of GnRH. And so they're not able to release LH and FSH. And also they would have anosmia, and she doesn't have anosmia, so that's out of the equation. Klinefelter would be 47XXY. So 47XXY would be Klinefelter syndrome, and in that case you would see small streak fibrous testes, which is not seen here, so that's not the answer. The answer would be Mullerian agenesis. And so just to kind of understand you know pathologies of this sort, you want to basically see the functions of each hormone and how they act on the internal and external genitalia. So when you have an XY gene, you're obviously going to develop testes, and these testes have the Leydig cells and the Sertoli cells. When you have XX, you're going to develop ovaries, obviously, and you have estrogen production and testosterone production from the theca internal cells. Now, the Leydig cells are going to secrete testosterone. Okay, that testosterone is going to give rise to your secondary sexual characteristics, and that would be pubic hair, axillary hair, the penis size, growth spurt, facial hair, etc. And this testosterone also needs to be converted to DHT in order to give rise to your external male genitalia, like the penis, scrotum, and prostate, via 5-alpha reductase. Okay. And this testosterone also gives rise to your primary sexual characteristics like internal male genitalia. So that would be seminal vesicles, epididymis, all of that stuff, which comes from your Wolffian duct. The Sertoli cell's main function right now is to release Mullerian inhibitory factor, which prevents the formation of Mullerian duct into your internal female genitalia, which includes the fallopian tubes, uterus, and proximal vagina. Testosterone here mainly gives rise to your secondary sexual characteristics, and estrogen gives rise to both primary and secondary sexual characteristics. So usually if you have Mullerian duct being, if the development of Mullerian duct is kind of, inhibited or is stopped in a manner, then that would lead to a malformed uterus or a malformed fallopian tube or proximal vaginal canal. And as a result of that, you would basically have primary amenorrhea because your uterus or your primary internal genital organs are not developed properly. So that's what's happening in this case here. She has Mullerian agenesis, which is why she has only a short external vaginal canal and then a rudimentary uterus. Okay. These are the sex chromosome disorders. You have Klinefelter, Turner, you can read it. And then you have aromatase deficiency and all of these other not chromosomal disorders, but disorders within the development of sexual characteristics. Here we have Mullerian agenesis and androgen insensitivity syndrome. And basically sometimes people get confused if it's Mullerian agenesis or androgen insensitivity. But in Mullerian agenesis, they're very much going to tell you that it is going to be a hypoplastic uterus or a rudimentary uterus, and you're not able to pass the probe further into the vaginal canal. So that's a very clear indicator of Mullerian agenesis, and you have normal levels of hormones here. However, in androgen insensitivity syndrome, the body is trying to combat that insensitivity to androgens by producing more and more testosterone and estrogen. The estrogen is produced in response to more testosterone because of aromatization, actually. Wait, I think I made a mistake in this question. Well, not really a question, but I think I made a mistake in the way I explained it. Where did that go? There was a PCOS question, and I think I said testosterone is converted to estrogen with the help of estrone and with the help of 5-alpha reductase, and that's not really the case because testosterone is converted DHT with 5-alpha reductase here, and testosterone is converted to estrogen with the help of aromatase. So I think I definitely did make a mistake here with that PCOS question where I told you guys that testosterone is converted to estrone with the help of 5-alpha reductase when it's actually aromatase. I can't find it here yet. Yeah, here I did say it's not 5-alpha reductase. I'm so sorry. This is aromatase. So androgen is converted to estrogen, while aromatase 5-alpha reductase acts upon the androgen and converts the androgen to DHT. All right, so oh my God, what did I do? Sorry. Yeah, here. So testosterone and estrogen are pretty high in androgen insensitivity syndrome. Reproductive organs are absent in Mullerian agenesis, but you do have normal ovaries. And then you don't have uterus or vagina here. You just have cryptorchid testes, and breasts are normal in both these scenarios. Secondary sexual characteristics are pretty much normal in Mullerian agenesis, but in androgen insensitivity syndrome, they're minimal to absent, mainly because you don't have receptors responding to that androgen. Okay, moving on to next question, we have question number 23 here. So here we have a 53-year-old postmenopausal woman. She's concerned about pale areas on her labia that have been slowly enlarging for the past year. So she's postmenopausal, okay, and then she has these white areas on her labia. The areas cause discomfort. She become easily irritated. Physical exam shows gray to parchment-like areas of skin that involves most of labia majora, labia minora, and introitus. The introitus is narrowed, and a biopsy specimen is taken and microscopically shows thinning of the squamous epithelium, a dense band of upper dermal hyaline collagen, and a scattered upper dermal mononuclear inflammatory cell. What is the most likely diagnosis? So this is going to be a classic scenario of how she's postmenopause. She doesn't have insulin. She doesn't have estrogen, and as a result of the lack of estrogen, the skin down there is undergoing atrophy. So this is going to be lichen sclerosis atrophicus, extramammary paget disease. Would not present with symptoms of like pruritus and like pale areas that are all over her labia, and like the biopsy would not show skin thinning of the squamous epithelium. Rather, it would show paget cells. HPV infection would not necessarily manifest with skinning of the squamous epithelium, and pelvic inflammatory disease would not manifest with all of this. It would rather manifest with like tenderness, adnexal tenderness, and things of that sort. Vulvar intraepithelial neoplasia, you would see that the entire thickness of the epithelium is involved with atypical or hyperplastic cells, and not just whatever this presentation is. And when we're talking about vulvar pathology, we have the Bartholin's list and abscess. We have the lichen sclerosus simplex, and then we have the lichen simplex chronicus. So this is lichen sclerosus simplex, and this is the chronicus one. So this is basically seen, the sclerosis is seen in usually prepubertal and peri to postmenopausal females, and they present with intense pruritus, dyspareunia, dysuria, dysgeusia. Sometimes there is an increased risk for developing skin cancer, whereas the chronicus usually is just hyperplasia of the squamous epithelium, so elongated rete edges. And this presents with a leathery, thick vulvar skin instead of a, pale white plaques, which are eroded or ulcerated. And enhanced skin markings because of chronic rubbing or itching, but there is no risk for squamous cell carcinoma. Moving on to vulvar carcinomas, you have vulvar intraepithelial neoplasias, which give rise to, more malignant forms of the disease. So, these intraepithelial neoplasias can be associated with HPV, and they don't necessarily have to be associated with HPV. So once associated with HPV, you will see kelocytes. And the ones without that, you don't see kelocytes, obviously. And then malignant transformation takes place to basiloid and or T lesions. And then the non-HPV usually has a malignant transformation to keratinizing squamous cell carcinoma. And again, you have keratin pearls in squamous cell carcinoma, so it's very easy to diagnose this. Where for basiloid and wart, you kind of just have to memorize them. And then the HPV is of the type 16 and 18. And very much similar to your CIN as well. Extramammary patch disease is usually, again, intraepithelial adenocarcinoma, but this does not arise in the setting of an already present carcinoma within the vulva, just unlike our patch disease of the breast. And here you will see that it stains for S100. So it kind of resembles the melanomas because of it kind of resembles the melanomas and it stains for S100. And it also stains for this blue stain, meaning that it has like mucin production, and then you'll just see Paget cells on biopsy here. Moving on to clear cell adenocarcinoma, this is usually in response to exposure to DES, which is diethyl sylvestrol in utero. But now usually you don't see this as often because they've stopped this completely. But you will see clear cells, so clear cell adenocarcinoma, so you'll see clear cells here, things of that sort. And then sarcoma, I don't know how you pronounce this. I'm not even going to try. So you have sarcoma, which are basically grape-like lesions that kind of, they emerge from the vagina. So if you see anything that, says that's grape-like lesions emerging from the vagina and the patient's pretty young, then you will know that it's a sarcoma or a embryonal rhabdomyosarcoma. And you will see that you have spindle cells here, spindle cells that stain for Desmond. And yeah, that's about it. Moving to question number 24, I think you have 2 more questions left and we're almost done. So, or actually 3 more questions left and we're almost done. So a female infant here is born at term to a 41-year-old Yupik woman after an uncomplicated pregnancy. Soon after birth, the neonate develops hypotension. Physical exam shows ambiguous genitalia with prominent clitoris. Lab findings show low sodium levels. Potassium levels are all right, I guess. Somewhat elevated, you could say. Usually potassium levels are from 3 to 5, so it's 5.1. Chloride is 93, carbon dioxide is 18, glucose is 65, creatinine is 0.4. Testosterone is 50, and normally it should be less than 30. So the female infant has high levels of testosterone, and she has hypotension, and cortisol levels of 2. Abdominal ultrasound scan shows bilaterally enlarged adrenal glands, so congenital adrenal hyperplasia. Which of the following enzyme deficiencies is she most likely to have? So the way I would remember the clinical manifestations of each adrenal deficiency would just by doing this. So I would write 21, 11, and 17. Then I would write the blood pressure and their realizing symptoms. So in 21, you have realizing symptoms, but you have low blood pressure. In 11 hydroxylase, you have both high blood pressure and realizing symptoms. In 17, you have only high blood pressure. And so that's like how I would remember. So if a patient comes in with hypertension and realizing symptoms, I would know that it's 21 alpha hydroxylase deficiency. If a patient is coming in with both high blood pressure and realizing symptoms, then I do know this is 11. And if a patient comes only with high blood pressure and no of realizing symptoms, or if a male baby comes in with ambiguous genitalia because there's no androgens, then I would know this is 17. So that's how I would remember it. I honestly did not bother learning this entire pathway because I just, yeah, this is like the one way I could remember. But we can go over it. So when we're talking about 21 alpha hydroxylase deficiency, we are basically inhibiting this pathway here. So your progesterone is not getting converted to 11-deoxycorticosterone. Your 17-hydroxyprogesterone is not getting converted to 11-deoxycorticosterol. So this pathway is completely blocked. So all of your things are shunted down to this pathway. So you have elevated levels of testosterone. And in a female, and because this pathway is blocked, you're no longer producing aldosterone either. So a female would come in telling, a female infant would come in with ambiguous genitalia because there's a lot of testosterone. And because there's no aldosterone, she would have low blood pressure. So she would come in as a hypotensive patient with ambiguous genitalia. A male patient necessarily would not present with ambiguous genitalia. He would just present with low levels of blood pressure because of low aldosterone. Okay. Now, when we're talking about 11-beta hydroxylase deficiency, we are essentially blocking this pathway down. So when we're blocking this pathway down, 11-deoxycorticosterone is no longer converted to aldosterone, and then 11-deoxycortisol is not converted to cortisol in the first place. So the pathway, again, is shunted down to this way, and testosterone levels are up. But here, in this scenario, 11-deoxycorticosterone kind of acts like aldosterone on the collecting tubules. So so the patient is going to have normal to high levels of blood pressure because this kind of works as aldosterone, but they will have an ambiguous genitalia. We're talking about female patients here. Okay, we're talking about female infants, so ambiguous genitalia with a normal to high blood pressure. If it's a male patient, then you will be able to know that it's just going to be elevated levels of blood pressure, and it's going to be 11 beta hydroxylase deficiency. Now, if we're talking about 17 alpha hydroxylase deficiency, we're effectively blocking this pathway. So when we're blocking this pathway, all you can do is shunt the pathway to this area. And so usually females will not have realizing symptoms, but they will have high levels of blood pressure. So elevated blood pressure is going to be there. In males, however, you will see elevated levels of you will see ambiguous genitalia and you will see elevated levels of blood pressure, mainly because you don't have testosterone being produced now. So that's how I would remember it. And our answer here is 21 alpha hydroxylase, mainly because she's a female infant who is hypotensive and she has realizing symptoms. Now, question number 25. Here we have a 34-year-old woman who comes to the office for follow-up after 2 abnormal pap test results. The patient has had 4 lifetime sex partners, oral contraceptive pill usage is there, she's never been pregnant. She has no chronic medical conditions, does not use tobacco, alcohol, or recreational drugs, and physical exam is normal. Cervical biopsy, you will see high grade intraepithelial neoplasia. So I'm assuming this is probably CIN2 or CIN3, most likely 3. Which of the following microscopic findings is most likely to be present in the tissue sample? So atypical glandular cells invading the basement membrane. Cervical epithelium, so glandular cells are no. It's supposed to be squamous cells. Cells with nuclear atypia in the lower third of the epithelium only. This is CIN1, and this is usually low grade, and it's clearly said here it's high grade, so no. Cells with perinuclear vacuolization only. So this is coilocytes. You will see coilocytes here, but they've literally said here high grade cervical intraepithelial neoplasia. So you won't just see coilocytes, you will also see atypia. So that's out of the equation as well. Expansion of atypical basal cell towards the epithelial surface. That could be a very much possible answer. Nests of atypical cells in the subepithelial stroma. So nope. So the answer is D. So when we're talking about cervical cancer and cervical intraepithelial neoplasia, this is usually atypical cells that begin at your transformation zone, which is like the basal layer of the squamous-columnar junction, and it kind of then extends out from there. So they're classified as CIN1, CIN2, and CIN3. And this depends on how much of the layer of the epithelium is involved, and associated with HPV 16 and 18, where 16 kind of blocks the E6 gene product, where E6, so 16 blocks the E6 gene product, and 18 blocks, which produces, so 16 and 18, right? So it's associated with HPV 16 and 18, and they both produce the E6 gene product and E7 gene product. So E6 usually inhibits TP53 and E7 inhibits the PRB gene product. So HPV 16 and 18 have E6 and E7, and E6 acts on TP53, E7 acts on PRB. And you will see coilocytes here, which are usually, you have a halo, which are cells that have a halo around the nucleus. And these are usually very much pathognomic for HPV infections, and this can, progress to invasive carcinoma if left untreated. Usually asymptomatic, so you have to do a pap smear on a 3-year basis, and will mostly present as abnormal vaginal bleeding. Risk factors are multiple sexual partners, not using condoms, smoking, immunosuppression, things of that sort. And then invasive carcinomas are usually squamous cell carcinomas because this happens at the squamous-columnar junction, right? It could very rarely be adenocarcinomas, but it's very often, very commonly squamous cell carcinomas. And this can be detected using pap smear with biopsy, so colposcopy and biopsy. Sometimes this can lead to renal failure in the sense that it can block ureters and lead to hydronephrosis. So yeah, important concepts would be to remember the risk factors. It's kind of tilted. Sorry. So risk factors for cervical cancer would be infection with high-risk HPV strains. So remember, 16 and 18 produce gene products E6 and E7. E6 blocks TP53 and E7 blocks the PRB. And if they've know one thing about STIs is that if someone has an STI before, they're likely to have another sort of STI. So it's STIs are usually, as Dr. Muhammad says, they're buy one get one free. So if someone's co-infected with an STI, it's a very high. If someone's infected with an STI, then it's a very high likelihood that they're going to be co-infected with another form of STI. Early onset of sexual activity, multiple or high risk sexual partners. So if you're not using barrier protections, you could, develop cervical cancer, and immunosuppression, OCP use, low socioeconomic status, and tobacco use. Right now, we do have vaccines for HPV, not cervical cancer, but we have vaccines for HPV strains, and it's very much encouraged for all of us to get vaccinated against the HPV strains because you're kind of preventing, like it's a curable cancer in the sense that you have a vaccine for that cancer. So everyone's very much encouraged to get HPV vaccines either ways. So this is how the CIN looks like. So you would start off with CIN1 here, involving just like a small thin layer here, and then CIN2 would involve a bigger layer. CIN3 would involve the entire layer, and then invasive one would be invading the base membrane. So yeah, this is how it looks like on histopath. So this is the normal one. You start off with CIN1, which involves only the basal layer. You have CIN2, which starts going upwards a bit. So that's one thing. And then CIN3 involves the entire thickness of the epithelium. So that's CIN3. Last question, and we're done. So here we have a 52-year-old female. She's being seen by her family physician. And over the past year, she's gained 45 pounds, which is concentrated mostly in her abdominal region. She also complains of fatigue and weakness in her arms. Her vital signs are temperature of 98, pulse of 89, blood pressure 157. So high blood pressure. Physical exam reveals the patient to have comparatively small arms and thighs, abdominal striae, and hair on upper lip. So classic Cushing's. Lab testing shows blood glucose concentrations of 173 because we know cortisol is diabetogenic. So that's why she's having elevated glucose levels. And we also know that cortisol, increases blood pressure, which is why she has elevated blood pressure. Serum cortisol drawn at 3 is 44, and this is elevated. Let me just cross-check that. I should have had normal values written down, but I didn't, so. Okay, so yeah, this is elevated. A low dose dexamethasone test does not elicit a change in the cortisol concentration. So nothing happens if you give low dose dexamethasone, but after you give a high dose dexamethasone suppression test, the cortisol concentration decreases to 21, which is a normal cortisol concentration. Which of the following is most likely the source of her elevated cortisol? So usually with Cushing's, the way you want to approach Cushing's, so she's having classic Cushing syndrome, and the way you want to approach Cushing's is by doing either a urinary free cortisol level, or you want to do the saliva test of the cortisol, or you want to do a low dose dexamethasone test. When you do a low dose dexamethasone test in a normal patient, usually if you give corticosteroids with cortisol, if you give corticosteroids on top of cortisol, that's going to suppress ACTH, and that's going to suppress the release of cortisol as a whole. So if you do give low dose dexamethasone, and if it suppresses cortisol, the patient's completely normal. However, if low dose dexamethasone does not suppress your cortisol and the cortisol remains high, then it's Cushing syndrome, okay? Cushing syndrome. Now, you want to see if it's because of a pituitary adenoma, if it's because of a adrenal adenoma. So what you do is, or if it's ectopic ACTH secretion, okay? So you do a high dose dexamethasone test. When you do a high dose dexamethasone test and you see that cortisol is suppressed, then that's Cushing's disease, meaning that it's pituitary adenoma. Because usually if you give high dose dexamethasone, this is going to inhibit pituitary-derived ACTH only. So pituitary-derived ACTH only is going to be inhibited with high-dose dexamethasone test. So if you inhibit pituitary-derived ACTH, you also inhibit cortisol. So cortisol declines or becomes normal, and that's Cushing's disease. However, if high-dose dexamethasone test is not able to suppress cortisol, that means that ACTH production is not from the pituitary, it's from somewhere else. Okay, so you want to check how much you want to check the levels of ACTH in the first place. So if the levels of ACTH are super high, then it's ectopic ACTH production from small cell lung cancer or medullary carcinomas. If it's low ACTH, then it's an adrenal Cushing's disease. So note that high dose dexamethasone tests primarily suppress pituitary ACTH, and if you see cortisol going down in response to high dose dexamethasone, then it's definitely Cushing's disease. However, if it doesn't go down in response to high dose dexamethasone, then it's either Cushing's syndrome because of adrenal adenomas or Cushing's syndrome because of ectopic ACTH secretion. Both of these do not respond to high dose dexamethasone test. So here, a low dose dexamethasone test did not elicit a change in cortisol concentration, meaning that she definitely had Cushing's syndrome, because if this did decline the levels of cortisol, then she would have been a normal patient. However, after a high dose dexamethasone suppression test, the cortisol concentration decreases to 21. So high dose dexamethasone test does have an effect on cortisol levels. And so the answer would be pituitary adenoma, because high dose dexamethasone only works on pituitary derived ACTH rather than any other ACTH. So yeah. And I think we covered almost everything, or almost everything that was high yield. I'll just go talk about adrenal insufficiencies, because that's something that we didn't cover yet. So adrenal insufficiency is that you're not able to produce cortisol and mineralocorticoids for the body's needs, glucocorticoids, mineralocorticoids for the body's needs. And it can be acute in the sense that it could be after infection, or it could be chronic in the sense that there could be a autoimmune disease responsible for it. So you would have symptoms like, weakness, fatigue, orthostatic hypotension, because we know that cortisol is responsible for maintaining blood pressure. And if you don't have cortisol and if you don't have mineralocorticoids, you will have a decline in blood pressure. And so you will have orthostatic hypotension, you will have muscle aches, weight loss, GI disturbances like sugar or salt cravings. Treatment is to obviously replace the glucocorticoids and mineralocorticoids, because, you don't have them in the first place. And so primary adrenal insufficiency means that there's something wrong with the adrenal gland itself. And so when there's something wrong with the adrenal gland itself, it's not going to produce enough cortisol and aldosterone, and that's going to lead to hypotension. So when there's no aldosterone, you're not reabsorbing that sodium in water, rather, you're peeing it out. And also you're going to be having high levels of potassium and H+, and that will lead to metabolic acidosis and hyperkalemia. Okay, and because the problem is primarily within the adrenal glands, your pituitary is going to start overproducing ACTH. And when that happens, you're going to have hyperpigmentation on your skin and your mucous membranes. So usually that's seen in scenarios of primary adrenal insufficiency. Addison's disease is usually chronic primary adrenal insufficiency caused by adrenal atrophy or destruction. And this is mainly because of some autoimmune condition going on, or it could even be because of TB in resource-limited countries. With secondary and tertiary adrenal insufficiency, you kind of have, so here the problem is not necessarily within the adrenal glands. It's mainly either secondary, so it could be decreased ACTH secretion from the pituitary, or decreased CRH secretion from the hypothalamus, and that would be tertiary. So in this scenario, you wouldn't necessarily have hyperkalemia, because what did I say? Aldosterone was mainly like regulated by the RAS system, right? So if this system's working fine, and if the adrenal gland is functional enough to produce aldosterone, you don't necessarily have hyperkalemia and metabolic acidosis. And you don't have hyperpigmentation as well, because if you don't produce ACTH in the first place, you don't have hyperpigmentation. If there's no CRH secretion in the first place, there's no ACTH secretion, and you don't have hyperpigmentation. Secondary adrenal insufficiency is usually because of pituitary pathologies, like we mentioned here, ACTH secretion, tertiary is CRH secretion, um, or it could be because of abrupt cessation of chronic glucocorticoid therapy. So basically, what happens is when you're hooking the patient up on chronic glucocorticoids, in case the patient's having an autoimmune condition, or in case the patient's like a Crohn's patient or a ulcerative colitis patient, and you hook them up on glucocorticoid therapy for a good chunk of time, that essentially suppresses your HPA axis, meaning that because there's so much glucocorticoids, that's going to have a negative feedback on your CRH, that's going to have a negative feedback on your ACTH, and as a result, your adrenal glands are going to atrophy. So that's why you will have tertiary adrenal insufficiency, mainly either from CRH, but it's most commonly because of treatment with glucocorticoids. And if you stop that treatment, your adrenal glands have already atrophied. There's no other way of producing cortisol or mineralocorticoids. And then acute adrenal insufficiency, also called as Addisonian crisis, usually is often seen in scenarios where the patient's faced with situations of stressors like fever or surgeries, in which case they require more glucocorticoids and these patients, mind you, are already insufficient with glucocorticoids. So basically what happens is they're faced with an acute stressor. So this could be any sort of injury, stress, trauma, fever, and surgeries. This often requires the body to produce a lot more glucocorticoids to kind of calm down whatever stressor is going on. And they're not able to produce that because they already have some sort of pre-existing adrenal insufficiency, or they're already on glucocorticoid therapy, because we know that glucocorticoid suppresses this entire axis and leads to adrenal atrophy. So usually this will present with acute abdominal pain, nausea, vomiting, altered mental status, or shock. And Waterhouse-Friderichsen syndrome is seen in the setting of Neisseria meningitis, which is basically bilateral adrenal hemorrhage, in the setting of sepsis. And how would you diagnose what type of insufficiency it is? So you want to check AM cortisol. If your AM cortisol is low, or if you don't have cortisol peak in response to ACTH, then you want to measure ACTH. And then if your ACTH is inappropriately, so if your ACTH is high, then it's definitely primary adrenal insufficiency, because your cortisol is not being released in response to ACTH. And if ACTH levels are high, it's primary adrenal insufficiency. However, if ACTH levels are low or inappropriately normal, this is going to be secondary or tertiary adrenal insufficiency. Anyway, that's about it for my patho questions. Like I said, for SAQ, MCQ, OSCE, you need to hammer down images in your brain. You need to remember them. And if you do end up remembering a lot of them, you will end up scoring a lot of free points on your exam. And I really do hope you guys have an easy exam. I did make a radiology summary, like I mentioned, last year, which had all the, imaging that was there in the lecture. And so I don't know if you guys have the same lectures as you do from our batch. And if you do have the same lectures, then I would tell you that you can rely on the summary for a good last minute revision. And yeah, it's taking a while to open, honestly. But this is the file. It's 41 pages long, and it kind of has the clinical correlation with the imaging. Anyway, if I said something stupid, if I said something wrong, if I made a mistake, please, please, please contact me, and I'll, clarify ASAP for you guys. You can contact me on my email, on my, phone number, just text me. Any sort of feedback is welcome. You can directly text me the feedback or email me the feedback, or, scan the code for the feedback actually. And you have any questions, please do not hesitate to contact me. I will try my best to respond ASAP. And I hope this session was really beneficial. And yeah, keep me in your prayers for my surgery final, because that's one hell of a final. And I'm really screwed for it. So yeah. Anyway, thank you.